Good afternoon, everybody. Thanks for coming to the Health and Wellbeing Board. So welcome to the meeting of the Health and Wellbeing Board. I'm Michael Squires, Cabinet Member for Health at Leicestershire County Council and Chair of this board. This meeting is being broadcast live via YouTube and it will be archived so you can view it afterwards. Please turn off your microphone on speaking and remember to turn it off afterwards. Apologies, we've received apologies from Councillor Pugsley, Matt Gaunt, ICB. We've also received apologies from Yasmin Sidyot. Matt Gaunt. So Yasmin Sidyot is here instead of him. Yes, I've got it right now. We've also received apologies from Jane Moore. We welcome to the board for this meeting Nikki Collins from the Children and Families Department. That's fine. So agenda item 1 is the minutes. So I propose that the minutes of the meeting held on the 25th of September 2025 are taken as read, confirmed and signed. Do I have a seconder? Thank you. Are we all in agreement? That's it. Okay, thank you. Agenda item 2, urgent items. There are no urgent items. Agenda item 3 is declarations of interest. I have a declaration myself. I have a standing interest in all substantive agenda items due to my employment with LPT. Do any other members have any interest which they wish to declare in respect to this agenda? Yes, I can't quite see your name there. Yeah.
Geoffrey Coffin, my son is employed by NHS England. I don't know whether, is that appropriate to declare at this stage?
It's worth mentioning, but
I can post as well.
Always worth over declaring, you don't lose any points for it. Anybody else? Yeah. Okay. Next we have my position statement. Copies have been emailed to you and a version is also published on the council's website. I won't read all of it because it is quite lengthy, but I will read the first 2 paragraphs which I think are fairly significant. As we approach winter and the increased pressures that it brings on services, we want to emphasise the vital importance of staying up to date with vaccinations and immunisations. An ICB immunisation programme team works closely with the LLR councils, including public health and adults and communities departments, to plan and implement priority vaccinations. In the last few years, these have included COVID vaccines twice a year, flu annually, one-off RSV, and an opportunity for catching up with missed childhood vaccinations, all for the relevant prioritised cohorts. This cross-system teamwork on vaccinations is expected to continue indefinitely and is presently coordinating and overseeing the county autumn-winter vaccination programme. Care homes for older people continue to be prioritised for vaccinations, and this remains a key performance measure for this programme. I will add, if you haven't managed to get one, you can very easily just go onto Google, put vaccine and book at a local pharmacy. So agenda item 5 is the mental health place-based subgroup progress update. This report provides an update on progress in delivering against the joint local health and wellbeing strategy priorities. To present this report, we have Fiona Grant, consultant in public health, and Victoria Charlton, mental health strategic lead, both of Leicestershire County Council. The floor is yours.
Thank you. So the purpose of the report is to update the Health Wellbeing Board on the work of the mental health place subgroup, delivering against the joint health and wellbeing strategy priorities. So in terms of recommendations, the board are required to note the progress that's been made over the last 12 months and to support the work of the group, including helping to overcome some of the barriers we've experienced around data sharing and to help facilitate progress in some areas of work. So in terms of policy framework and previous decisions, so point 4 on your reports, The mental health place-based subgroup was established in February 23, and as well as being a health and wellbeing board subgroup, the group also acts as the place-based group for the LLR Mental Health Collaborative, so it has that dual function. And the mental health place group is now really well established with representation from quite a wide range of partners. So that includes voluntary community sector, LPT, ICB, etc. So quite very well represented, and the group works very well as a partnership. So good mental health and well-being is obviously an important part of overall health, and there was recognition of this in setting up this subgroup originally, that we want to move towards having that parity with physical health. So the priority areas of the place-based group are largely drawn from the health and wellbeing strategy, but also along with the joint strategic needs assessment recommendations around mental health. So there have been two of those, one around children and young people and one around adults. And a delivery plan has been developed around those priorities for the group based on a life course approach. So there are a number of different elements of the plan. So that's under point 8 in the report. And I'll go through those briefly. So a key part of the plan includes developing a mental health promotion plan around prevention. And the work is being led by Public Health. It's underway, and part of that includes a 5 Ways to Wellbeing campaign that we're looking at delivering throughout 2026. So that mental health promotion plan is very much about prevention, but it's that low-level prevention stage. Another key element of the plan is around children and young people, really supporting and enhancing the children and young people offer around mental health and wellbeing, including the transition from child to adult services, which we recognise is a really key and potentially vulnerable stage for children and young people. And the work is ongoing with partners working together to help understand and particularly to promote access and awareness of the different levels of support available for children and young people in relation to mental health. So we sort of recognise that there are different levels of help and support around mental health, and often people would tend to sort of go for for example, the CAMS services, for example, that people will be aware of, and we want to really sort of heighten and strengthen the opportunities to access the range of other services that there are in place as well. Health inequalities is a key part of the work that we're trying to address again as a key priority, and there's been a particular focus in the last 12 months around people with serious mental illness. So it's really recognising that people with serious mental illness, we know, tend to live, sadly, 15 to 20 years shorter life expectancy than those who don't have a serious mental illness. So really recognise that as a health inequality that we want to address as a system. And one of the key areas of work in trying to address that has been around improving health check uptake. So historically, the health check uptake of people for serious mental illness, particularly in the county, hasn't been as good as, for example, it is in the city. So a lot of work has been going on around that, led by ICB colleagues and working in partnership with other key stakeholders. And in terms of that health check uptake and actually the follow-up, there's 6 different health areas that are looked at, and the follow-up around that is important as well. So, for example, smoking cessation, alcohol, blood pressure, etc., are part of those. But we're now in a position where we are now at 67% uptake, so that is an improvement, and we're statistically significantly better than the national average, which is 60%. So there's been some progress there. More broadly around health inequalities, another area that we've identified is around improving breast cancer screening uptake in people with SMI. So this was something we initiated as a priority in the county. So we recognised that a key factor in premature mortality in people with SMI is down to cancer, and that was identified in the health needs assessment for adults a couple of years ago. And one of the things that we've looked at is breast cancer screening uptake is really poor. It's about half of what it is. So if you look at people with SMI, it's about half of what it is in the general population. So we've done a lot of work around that, and Emma is going to talk about that in more detail in a couple of minutes. But just to say that it's been a system-wide piece of work. It's now been adopted across the LLR Mental Health Collaborative, and we've done that work using the Health Equity Audit tool to really look at how we can make a difference there. Suicide prevention, so supporting the work of the LLR Suicide Audit and Prevention Group and the Strategy Refresh. And I know many of the members around the table today will be aware of the work that's been done around that Suicide Prevention Strategy Refresh, and that a number of different partners have been involved in that refresh and the engagement and the rewrite and the sort of developing the priorities around that. And we're now at the point of looking at implementing different elements of that around those priorities. So the suicide prevention strategy refresh is now complete, and it's really about the implementation now. And an example of activity related to suicide prevention is detailed below, and I'll talk about that a little bit more in a few minutes. Dementia is another one of our priority areas that we've identified through the mental health group, and particularly flagged up, we're around doing something around prevention. So we're recognising that there are some modifiable risk factors around people developing dementia that aren't necessarily very well known, and we want to do a piece of work around that. So that will happen next year. And also recognising one of the key issues historically we've identified as dementia diagnosis rates in the county have not been as good as they should be, and not been as good as other parts of the system. I'll not talk too much about dementia because I know that John and Amina will talk about that specifically later on in the agenda, but just to say it's an important part of the work that we're trying to do. And then finally, wider determinants, so really addressing the impacts of wider determinants on mental health and well-being, which includes social factors such as employment, housing, gambling harms. We know that mental health colleagues, ICB colleagues particularly, talk about how perhaps a few decades ago they didn't see so many people accessing mental health services for social reasons, or perhaps driven by social reasons, but they feel as if that's happening much more now. So as a system, we want to do some work around that. And district council colleagues are working particularly around homelessness and looking to see how can we make sure that those people who have that double kind of disadvantage, if you like, of homelessness and potential mental health issues as well, are able to access help and support for their mental health. And we're also looking more widely at those people with severe and multiple disadvantage, so those individuals who might have issues around their mental health, but perhaps also substance misuse issues, homeless issues, etc., just so that we're recognising those people who tend to have very complex issues and more challenging to address, but suffer particular health inequalities. So in terms of progress made in the last 12 months, we've outlined some particular highlights in the report, just to sort of flag up some pieces of work. So one of those is around supporting people with serious mental illness around stop smoking. So again, we talked about, I've mentioned this sort of lower life expectancy of people that we tend to see with SMI, and we know that smoking prevalence remains disproportionately high among people with SMI. So it is one of those ongoing issues. And what we identified through the local stop smoking services, when they looked at the number of referrals of people with SMI, they were very low indeed. In fact, I think they were virtually none. That's how poor it was. And so there's been a lot of work done across the system with different partners, and that's involved people from the IC. So for example, WAFA, that some of you are aware from the ICB's been involved in this. Some of the mental health neighbourhood leads have been involved in it, and Sabina from Public Health has been involved in really sort of driving this work forwards. And they've been able to identify what some of these issues were. And again, you can see through this report some of the things that have happened. So they've strengthened referral pathways for people from, for example, from mental health facilitators into smoking cessation services. They've developed a clearer process for referrals during SMI health checks. They have provided training for the smoking cessation advisors so that they've got a better understanding and are able to provide more adjusted and more appropriate services for people with SMI. And as a result of that, early indications are that service uptake amongst people with SMI is already improving. So almost immediately, having sort of really looked at this, they were able to increase the uptake, and we're optimistic that we're going to see quite a considerable uptake in due course. Another piece of work in a similar vein has been around, as I mentioned earlier, the work around breast cancer screening for people with SMI. And again, this is a system-wide piece of work, and Emma's going to talk about it in more detail in a minute. just I suppose the thing to say around that is huge amount of work has been done around that, but it's one of the areas where we've identified data sharing has been a bit sluggish, probably to say the least. And because of that, it's made it more difficult to progress the work in an effective and an efficient way. And hence we've mentioned that as one of the challenges in taking some of this work forwards. Suicide prevention, we've identified 5 priority areas through the Suicide Prevention Strategy Group, and in fact through the Suicide Prevention Strategy, the refreshed version, and they include suicide bereavement, so people who've been bereaved by suicide we know are at higher risk, identifying people in high risk groups and where are high risk locations, so quite a concerted piece of work around that. Children and young people, not because we have high numbers of suicide amongst children and young people, because fortunately that is low and it remains low, but we know that nationally it's increasing, so people felt that it was an important area to include. Self-harm, because we know people who self-harm are at higher risk of suicide, and leadership recognising that suicide is everyone's business, and it's that point of making sure that we've got that strategic join up and strategic leadership around making a difference. So under the umbrella of the Suicide Audit Prevention Group, actions are now being developed, and one of those key areas has been around building on the work around mental health friendly places and clubs. And so mental health friendly places is an initiative as a partnership project between the County Council and the City Council. And a mental health friendly place is one where organisations such as maybe barbers, hairdressers, kind of public facing organisations are able to receive training, resources, support, and ability to have a conversation with someone around their mental health and to navigate them to help and support around that mental health. And as a result of doing that work, a number of organisations have signed up to that. So it was launched in May 2024, and now there are 77 mental health friendly places in the county. And then on the back of that, a pilot project was developed around Leicestershire and Rutland County Football Association, so grassroots football clubs, really looking at how we can target men a bit more, because we recognise, so for example, with suicides, 3/4 of our suicides are amongst men, and we recognise that men are an important group that we need to be targeting. So there was an initial pilot with 5 local football clubs. That was very successful, in a similar way to mental health friendly places, providing that training, support, signposting ability. That was very successful, and as a result of that, that's now been expanded out to other sports clubs. So now it's been expanded out to cricket, rugby, bowls, as well as football. And it's hoped in the future to expand that out to non-sporting clubs as well. And to date, there are 43 mental health friendly clubs across the county. Around that one, there's been quite a lot of interest from other areas as well around that piece of work and how it's been set up. So it's very positive. So I will now pass on to Emma, who's going to talk a little bit more about the SMI work with screening.
Thank you, Fiona. So just to formally introduce myself, I'm Emma Burns. I work in health protection as a strategic lead for Leicestershire County Council. So the health equity audit tool, for those of you who aren't aware of it, it is a systematic process. It's a table in effect which provides some prompts, helpful questions, and really gets us to think about those and wider determinants of health, as well as the key area of work we're looking at. It actually helps us scope out our project work as well. So it's been really insightful and useful from that perspective. There are 4 main stages. So the first is to prepare. So that could be a literature review or gathering some local intelligence data, and then assessing that data or local intelligence to see how useful it is and where the gaps are in that information. And then there's the refine and apply section, and that's the stage we're at now. So we're working really hard to start refining some of the interventions that we've been working with colleagues on, and also applying them in practice, and then starting to collate that feedback to see A, if they're useful, but B, beneficial for the individual with SMI and taking up that breast cancer screening offer. And then finally, there'll be an evaluation stage. We're looking to begin that evaluation stage in around March 2026. So evidence has been taken both locally and nationally, and locally within Leicestershire, our overall population breast cancer screening coverage for those eligible people. So that would be the eligible cohort for 50 to 70-year-olds, for example, is around 70% year on year. And for individuals with an SMI for Leicestershire, unfortunately, that's as low as 31% that was highlighted in the adult mental health JSNA. So it's just a flag that it is an area of great need, and also this tool's providing some valuable insights. So breast cancer screening tends to be lower in that population, as we've pointed out, but trying to understand the barriers directly from the individuals with SMI has proven quite difficult, because our usual methods of focus groups isn't something that necessarily is appropriate or suits those individuals. So what we have done is called upon the assertive outreach team colleagues that have that really good working relationships, support those people with day-to-day activities. And it is just to note that not everybody with an SMI needs enhanced support. It will just be a certain number of people across our counties that do. And that's something that we have struggled to pull out from the data sets we've requested. But it is something that we've worked closely with mental health facilitators, and now mental health facilitators and our breast screening service at UHL are working closely together to overcome that barrier. So those themed barriers can be shared via some slide decks that can be shared later after the meeting if it's useful. And there's some information around what we discussed at a couple of the workshops that we used to inform this work. So any of the interventions that are planned for need to be planned for quite carefully. And that's because what we do not want to do is disengage people further than they may be already, especially for those who aren't in regular contact with primary care, for example, or their mental health support workers. So as I mentioned, we're on to that refine and apply stage, and some real positives that have come out is that the Mental Health Directorate for LPT have amended their SOP and added an addendum. So that addendum actually has a breakdown of a minimum offer for somebody with an SMI to be provided breast cancer screening support, and that's a real positive. And that would be that minimum offer, which then can be more personalised, and it has that potential for real person-centred focus and care provision. And it's also worth just pointing out that along the way of this heat, we have experienced some barriers in organisational working from ourselves in public health, communicating messages or action lists or tasks that we'd like support with, and we found a way around that in trying to operationalise those asks, so that we are going to our mental health facilitator colleagues with operational based tasks in a format visually that they would be able to just lift and pop onto their task allocation sheet. And something really simple, such as a Word document with a 4-quadrant charts, proved really useful to help support on that. And then from an evaluation point of view, we are looking, as I said, from March 2026 to start carrying out that work, and it will be a full evaluation. And we will continue to refine and apply throughout that evaluation process, because the lessons won't stop there, as I'm sure you're all aware. So it will be really important for us to continue to update that heat and really get the most out of it, and share our findings with OHID as well, which are really keen to learn lessons from ourselves on this project work. Thank you very much.
So much work, quite a lot of work has taken place over the last year really to progress the priorities in this important area. There have been some challenges, as we've hinted. One of the challenges has been around data sharing. Another challenge has been around stakeholders from organisations experiencing considerable change and uncertainty during the last year, which has been challenged. But despite that, the group continues to work really well. People are really motivated, really sort of keen to make a difference. And I think the group will continue to progress and to develop and build on the work that's already taken place this year. Thank you.
Thanks for your report. So I'll open the floor to any questions. Yes, Mike Sands. Actually, I'll follow Rachel first, actually, and then I'll go. Oh, I didn't see you too. Okay, yeah. Rachel Joe, please.
Yeah, thank you. Regarding Fiona's presentation, I just want to acknowledge the work that the mental health neighbourhood leads have done in terms of the wider determinants, and we're seeing some really positive impacts of that now. So that's a really positive piece of work. From the breast screening perspective, we've seen some really good results where we've put posters, leaflets, flyers within the mental health cafes. And I didn't know whether that's something that you've explored, but certainly I would say having that information in those environments has proved really helpful for some of the other campaigns that we've done. So it might be worth thinking about if it's not already there.
No, thank you. Thank you for that report as well. I think to note that there's a huge amount of progress that has been made, and that comes with really a lot of effort and work that happens across partnerships from health and care organisations. So that's something to note. Just a couple of questions that I had. I know, Fiona, at the end you mentioned a couple of the challenges. In terms of those challenges, which are ongoing, of course, but are there one or two key things that you would be looking for specifically to support from partners to help unlock? Particularly, I know you mentioned the information sharing and data.
Yeah, I mean, it's never an easy one, data sharing, but I think to quote one of the ICB colleagues, it's been a nightmare. One of the, some of the work around the SMI work, and we're nearly there now, but it's been quite difficult. And I suppose the learning from that it would have been good if the processes around data sharing were more transparent. And it would have been easier if, once we start to implement processes, it feels quite sluggish. Things seem to just get stuck in places for months on end. So I suppose the help would be, how do we prioritise our requests to sort of go a little bit higher than the chain, higher up the chain, because sometimes they just seem to get stuck. And also just having that clearer transparency around what the processes are would really help. I mean, we've managed despite that, but it's sort of been a challenge. Thank you.
I think the learning is really useful. It's about how quickly we can escalate those challenges internally and then be able to support in resolving them, considering the work, it hampers the work in terms of the delivery. On the SMI and the breast screening, you mentioned about the evaluation. What are the sort of key particular sort of things that you are looking at as part of that evaluation that you will see as sort of your key success factors?
Thank you. So one of the main success factors will be that our mental health facilitators will hopefully report that there hasn't been any disengagement within individuals with an SMI for their services, that the people taking up the breast cancer screening offer will feel supported throughout the whole process, including during the waiting phase, even though that is beyond the scope of the actual heat itself. It's something that has been raised, so it's important to incorporate those kinds of lessons as well and take them on board, and also to action them where possible. And also the 36-month round length for breast cancer screening. So that's the coverage round length, the average coverage round length, which is really important from a data perspective to see not just the 12-month snapshot in uptake for breast cancer screening, which could give you a certain number, but it's around that round length. So within that 3 years where somebody who might be called for screening, have they taken up the screening offer? Have the number of did not attends gone down? And that's something that we've requested via LHIS for data purposes, because that in itself will go on to help us. And regarding mental health cafes as well, flagging up breast cancer screening opportunities and awareness is really crucial, and mapping out all of those mental health care touch points, community and primary care and secondary care is actually in progress, and that's something that will form part of that evaluation also.
Yep, thank you, Chair, and thanks, Emma, thanks, Fiona, and thanks, Victoria. Trying to make a short question of a lengthy thing. I sort of there's an awful lot that goes on in mental health, and we've got this place-based subgroup, which I'm really pleased to see developing doing things, if you like, which are more within our gift. You know, it's about community, it's about prevention. It's not supposed to be a leading question, but I was wondering if you just tell us about how it then links into the mental health collaborative and the kind of more system-wide work, and the structures. So it kind of joins up with services. It clearly happens because that's Yasmin's question about taking forward the SMI stuff, but I'm trying not to say give us an overview of structures and groups and processes, but I just wonder if there's something about how does this fit with overall kind of mental health service collaborative work?
I'd say it's one and the same, really, like, because a lot of the work we do has this group has representation from all those key stakeholders, and although we've highlighted today what you might see is this less mental health servicey side of the work that we do, that's part of it as well. And as I sort of mentioned earlier, this group is also doubles up as a place-based group for the LLR Mental Health Collaborative. So it sort of has that dual purpose. So for this group, we're also feeding into the LLR Mental Health Collaborative. So we have that kind of system-wide linkage. But many of the people who sit on the LLR Mental Health Collaborative also sit on that place-based group. So I'd say from that wider mental health service perspective, it's incorporated into that, and we take on different elements of the work, albeit some of those service elements are more obviously led by, for example, health NHS colleagues. So ICB, LPT are well represented on those groups, and we would be playing a more supportive, the rest of us stakeholders would be playing a more supportive role. Does that answer your question? Yeah.
Thanks, Chair. Fiona Barber from Healthwatch. Hello, guys. Nice to see you again. Thank you very much for sharing the report. It really is fascinating to see just how much work there is going on. I echo the point that Mike made about how much or how many projects there are across the county impacting on people who are suffering from mental ill health. Just wondering, in reality, is there are a huge number of projects. How are we able to gather the impact that those projects are actually having in terms of outcomes for people in the community? Can we actually correlate all the hard work that's going on into these services into perhaps individuals improving health or improving ability to work or function within communities? And as importantly, I guess, is can we correlate all this work into the impact on health services? Are people wanting more health services, or can we say that because of all this work, we're seeing less demand? And the other thing, from Healthwatch is a lot of the feedback we get around mental health is really positive. People are so grateful that there is somebody there at a time of need, but sometimes there are also huge delays in accessing that support. So that's the other side, if you like, of the coin. So the key point really, I suppose, is about outcomes and how we're looking at that. Thanks.
So in relation to each of the priorities, we have a dashboard. So we have identified indicators that we monitor over time to assess whether or not we're making a difference in terms of those priority areas. So for example, you know, people with SMI, we monitor over time what the SMI health check uptake is, and those kind of things. So we have indicators, that metrics that relate to each of those priority areas that we do monitor the difference. And some of those are improving, some of those we are seeing better health outcomes. So some of those outcomes are around what I'd call process outcomes. So whether people are accessing services or not, maybe numbers of people accessing health checks. It's more difficult to be able to monitor if there's been an improvement in their health. But obviously where the data exists, we are trying to incorporate that into the dashboard as well. So I'd say largely we're using a kind of metrics dashboard to monitor that. So that's sort of more across the broader population. And then in terms of the individual projects, we try to build in monitoring and evaluation into those. So for example, where Emma was talking about the work around breast screening uptake, obviously we're looking at, has there been an increase in people with SMI? Have we reduced that health inequality gap over time. So we try to do that, and we try to incorporate as many measures as possible to monitor that impact. It is challenging though, because that's one of the challenges around the data, and especially if you're trying to do something around, for example, health inequalities, where it's a more targeted population you're trying to reach, because it can be quite difficult to target exactly where you want to reach without the right data, and it can be difficult to get the data to enable to demonstrate that we have actually made a difference, and that's part of what we're trying to do, to see how can we get the data that exists that is shareable to be able to monitor that impact. And other ways we monitor the impact are through things like case studies, through, you know, so we do use different approaches to try to demonstrate that. But yeah, there's different levels within it.
Thank you. Any other questions? Okay, well, I've got a couple myself. The first one, it might not be directly relevant, or you might need to get back to me. I don't know if anybody else might be able to best answer it, but I'll ask the questions and then you tell me. So the first question is, why are you aware why things like talking therapies aren't able to access NHS records? For example, if you've got a person with a high risk SMI that's you know, perhaps at quite a high risk of suicide, would it not be beneficial that they would be able to intervene a lot easier? Yeah, that would be my first question, actually.
Sorry.
Easily done.
Thank you. So the short answer is I'm not sure whether talking therapies can access that information. I guess potentially they can, but I'd be looking to other people involved in those services who might know. But certainly we do generally struggle, even organisations within, even services within the NHS, they do struggle with being able to access information across different services.
I think, Yasmin, you wanted to come in on that one.
Yeah.
I think what we're getting to is it's kind of, if you've got somebody, for example, who has had previous attempts and then perhaps doesn't declare them in a talking therapist referral, would it not be safer if they're high risk that talking services could access all of that information in advance?
I'll pick that up with the team to just check through in terms of how information sharing happens across services. There often is information that can be shared, particularly to support and safeguard individuals from a safeguarding perspective as well, and this would fall under that. But I will check that back and get back a response to yourself, Chair.
Yeah, thank you very much. My other question is, what support is available? I notice bereavement support is pretty high. I think it's number one priority, actually, that I was looking in the agenda pack. So what support is available for family members who are bereaved following a suicide? Because there is the 6 sessions of the Tomorrow project, but these people themselves are at high risk of suicide. So what support is there after that? Because 6 sessions is great, but what happens, you know, after that? Is it 6 sessions once a week for 6 weeks, I'm assuming? Don't quite know how it works.
And Victoria might want to come in on this because you're more involved with that service. But so in terms of service, so suicide bereavement support is available for families, working colleagues, for professionals, you know, to anyone who's bereaved by suicide. And my understanding was, I think initially they're offered 6 sessions, but it can be more than that, depending on what the kind of needs are of the individual affected. So there's the Tomorrow project, but there are some other organisations as well that offer bereavement support. But the main one that we offer and we commission, which is part funded by a number of partners around the table, is the Tomorrow project.
Right. Okay. And sorry, did you? I thought you said something.
Just
Okay.
sorry, Councillor Squires, just to
Yeah.
build on what Fiona said. So they are offered the 6 initial sessions. After that, there is a review, and if they need more, there'll be more sessions that's offered. Once they finish that block of that initial bereavement, there is an enhanced offer. They do offer counselling service as well, and so those individuals will be referred in.
they wouldn't just leave them sort of high and dry. If they needed additional support, they would provide that.
I think that will do for me then. All right. Any other questions from anybody else? Okay, well, thank you very much. So proposed motion that the board notes the progress that has been made over the last 12 months be noted and the work of the group and priority actions be supported. All in agreement? Thank you. Item number 6 is the Living Well Dementia Strategy, which is on pages 19 to 28. This report provides an update on delivery of the strategy. The report is going to be presented by Amina Begum, Senior Strategic Commission Advisor, Adults and Communities Department, but I will first invite Director John Wilson to say a few words. John, the floor is yours.
Thank you, Chair. So, as you just outlined, the report today is to provide an update on progress and challenges in the implementation of the LLR dementia strategy, which was implemented in 2024. Just two things I want to say in advance of Amina going through the report. The first is that we will be re-procuring the dementia support service in 2026. So if there are any comments that board members would like to make in following today's discussion in respect to the dementia support service and the re-procurement of that service, they would be very welcome. We haven't obviously written the specification yet, but we can incorporate any comments that come forward. The second is just to give a little bit of context to today's report. So nationally, work has commenced on a new modern service framework for frailty and dementia, which will focus on timely diagnosis, personalised care planning, and integrated equitable services. In terms of sort of the national, regional, local picture, I think it's fair to say that nationally there has been an increase in the dementia diagnosis rate, but it's still falling below the national targets. There's been a particular increase in diagnosis of women between the ages of 40 and 60. Significant increase, actually. I'm not clear as to whether or not that is replicated locally, but it's something that we could look into. In terms of the regional picture, the Midlands region has the highest wait time, the highest proportion of people over 18 weeks waits for referral to diagnosis. So we're at about 86% in the people waiting over 18 weeks across the NHS region. And locally, the number of people who have a diagnosis with a personalised care plan is below average in terms of the ICB area. In comparison to others, but the proportion of people with dementia diagnosis who are prescribed antipsychotic medication who don't have a diagnosed psychosis is above average. So some interesting things going on in terms of how we are treating and supporting people locally, I think, which provides a little bit of context to some of the things that Amina is going to go on to talk about in terms of the strategy and some of the challenges locally. So I'll leave it there and let Amina continue with the report. Thanks.
Thank you, John. Okay, so I guess my colleague came in February, I think last year, to report on the development of the LLR joint Living Well Dementia Strategy. And at that stage, the governance and the delivery plan wasn't drafted, but now it has. So we've really progressed within the last 12 months on a lot of the achievements that sit under some of those shared commitments across the LLR, including our ICB colleagues, around making a real difference for people with dementia and their carers. And this is built around the 7 pillars, which was around preventing well, diagnosing well, supporting well, living well, dying well, leading well and monitoring well. So, and this strategy is about delivering personalised, inclusive and high quality care at every stage of the dementia journey. So across all the LLR partners. However, we do have our localised place-based delivery plans. And again, in terms of those achievements, I'll go through some of those. But one of the things that we did do is build in a governance structure. So we've got the Dementia Programme Board, where we go on a regular basis to report progress on key areas under those 7 pillars on where we are at. We get highlight reports from key partners around what are they doing in terms of dementia care, any challenges, any issues. So then we kind of address that going forward. The other thing is, again, it's how we then link in with what Fiona's work around the mental health collaborative. So again, we take reports and air around some of those key achievements and align those things. In terms of some of the key headlines, as John said, we commission a joint service, which is the Dementia Support Service, across city, county and the ICBs. Now that is due to come to an end next year. So we've got plans to recommission that, but it's a really, really crucial service for people pre and post dementia diagnosis, provides really tangible, much needed service to support people manage their conditions, understand their health and well-being conditions, and signposting to the various services. It provides them with advice and guidance of other service areas. It provides them with peer support, and like similar people get together to share common understanding, and there are lots of memory cafes across city and county that people do really attend those. So one of the things that we did an annual evaluation, actually 70% of county population are actually using the dementia support service. Now the memory clinics are run by volunteers. The contract is being delivered by Age UK. So I guess the other bit in terms of our headline achievement is the one-stop health clinic, one-stop memory health pilot. That's a game changer at the moment, because what it's doing is actually enabling people to have one visit and be cognitively tested. Investigations are carried out that same day. They get their diagnosis as well on that same day, and then immediate care planning can happen. So people are not, referred to pillar to post and not really getting their diagnosis. So this is faster and it's less stress and better experience for the patient and the carer. We are going to do an evaluation, and this is funded by the ICBs. So hopefully when I come back again, we could report on what that impact has been and the usage of that as well. One of the other things is we're rolling out the Dementia 100 Toolkit, which drives consistency, quality across the system. And it's a practical tool, it's a national tool that helps organisations within the county to really look at, are we dementia friendly? What do we need to put in place to make sure that we are dementia friendly? And I think this has already been taken to the lived experience group, and they had a look at it, and there's going to be a rollout program of that. The other thing that's been achieved is public health campaigns around spreading the message around prevention and risk reduction, empowering people to take control of brain health and well-being. I guess the other bit I'll probably touch on now is much of the statistical stuff, which is the diagnosis rate. And again, as John said, the national target is 66.7%, and Leicester City is actually achieving a really good rate in terms of 72 to 73%. county is lagging behind in terms of 64%. So that means that 4,000 people may be living with dementia without a diagnosis. So we know that there are key challenges. And again, as part of our work with the ICBs and the work with other colleagues, what we're trying to do is really understand what are the barriers. So it could be the rural aspect to it. It could be that it's not inclusive in terms of isolated communities, the awareness. So those are some of the key challenges that we face and we will be looking into. And also one of the things that we want to do is, again, with health colleagues, is to look at GP referrals and work with GP surgeries to make sure that those referrals are taking place. And again, there's a piece of work that we want to do in terms of reaching out to seldom heard communities. So I know that county, we've got lots of rural aspects, and again, there could be transport issues. So we really need to look into that. So probably the next year's priority, we will try and weave that in. Some of the challenges is, as I've stated, is trying to close the gap around the diagnosis in rural areas, boosting GP referrals and workforce capacity, embedding cultural competence and inclusivity in terms of our service delivery, improving end-of-life choice for people with dementia, and looking at how impactful is the advanced care pathway, and do people really have a choice of where they die? So there's a lot of pieces of work that we need to pull together to understand, do people really have a choice when end of life is approaching? And in terms of some of the key deliveries, now again, we went to the Dementia Programme Board, the Mental Health Collaborative, and the Dementia Best Practice group as well, to showcase some of the achievements that we've done over the year. So I'll just quickly touch on those. So monitoring well. So one of the things that we've done as an organisation is really look at adopting a strength-based approach in terms of our assessment, how we commission services, how we monitor and contract services. So making sure that key elements of dementia is recognised and embedded in those principles of service delivery. In terms of preventing well, public health campaigns and outreach are in full swing, so they're taking place. The rollout, as I said before, of the Dementia 100 Toolkit is being adopted. Pilots of the one-stop clinics and the advanced pathways underway, so that's really good piece of work. Diagnosing well, so referral pathways are streamlined. One-stop memory clinic pilots are delivering same-day diagnosis and care planning. Hospital grants for carers who support people with dementia is also being utilised as part of a separate fund, which is the Accelerated Reform Fund. So we're going to get some learning from that. Has that truly helped people to take their loved one who have got dementia back home with the appropriate support? Supporting well. So in terms of the dementia support service, we will expand and make sure that that service is personalised, proactive, and is an outreach model to rural and isolated communities. We want to continue utilising memory cafes, because people that have got dementia and also those carers really find that useful, and it's reducing social isolation and building a community and connecting people together. So we want to continue doing that piece of work. And then living well, the delivery plans will be co-designed with people with lived experience. So again, as part of the Dementia Programme Board, there are little groups that sit underneath that. So hopefully there's the lived experience group. So we'll go to them and ask them what's important to them. What do they consider for us to take priority in looking into and really driving in change for those people? Because it's what works for them, and that's the only way we're going to get that evidence-based information, isn't it? And I think the other thing that we're doing consultation and engagement. We've developed some surveys, focus groups to really understand the impact of the dementia support service, where we need to make improvements, taking feedback from people with lived experience, their families, and also partners and practitioners that are referring into those services to really drive change. And the other bit is that we are also, as a local authority, reviewing our carer strategy. So hoping that there is a streamlined approach to all of this, because carers are caring for these people and we want them to continue caring. So what support do we need to still continue providing? So then that is sustainable going forward. I think in terms of recommendation, if the board can endorse the continued collaboration and improve, for us to continue to look at improving diagnosis rates and also the reduced health inequalities across the county. Help us to support commissioning plans to embed co-production, cultural competencies and carer support, and commit to another annual progress report probably next year or the end of next year. Yeah, I think that's it from me. I don't know, John, if you want to add any. That was a quick whistle talk.
Okay, thank you very much. I'm aware that's your first time, and you did very well. You ought to see my first time when I was chairing this meeting. I didn't do as well as that, so thank you very much. So I will propose that the board acknowledges progress made since February 20. Oh, sorry, I will not. I'll move to Yasmin Sijaz.
I mean, I support and endorse this. There's just a quick question around the memory assessment clinics and the pilots. Are those in place, and are you evaluating, or is colleagues evaluating that and sort of future thinking on that one? Thank you, please.
Yeah, so it is already being rolled out. So I think we're going to have another 12 years or 12 months, sorry, 12 years, 12 months of, seeing how that works out. But it'll be ICBs who will be evaluating that. So hopefully, again, with service user input as well as carers and then partners as well, to see if, the waiting list has really reduced, because and I think that's the other thing, isn't it? So Dementia Support Service is also looking at reducing the waiting list of the memory clinic. So hopefully when we come back again, we'll report on what the impact has been.
I mean, John, thank you. This is a really comprehensive report, and it's good to see what work's going on there. I've got an ask, an offer, and a question. So the ask is really the appendix. You've put that sort of map that pathway about having, is that something that we can share? Because obviously we've got a new charity leaders network that we set up at VAL. So it's like a load of CEOs coming together, and we're trying to pull together sort of like key documents to allow them to help support their staff, if that makes sense, if they are having service users at their services present with certain issues. And I think to have something like that we could put into a pack, obviously name checking yourselves, it wouldn't be us putting, we've made this up ourselves, obviously, to say where it's come from, but I think it would be a really good resource if we're able to use that.
So yeah, you could use
Thank
it.
you.
I pulled it together because for me, I need to see it pictorial, how it all kind of fits in. So yeah, definitely use that.
Brilliant. So that's great. I think the offer is obviously with regards to all the stuff that you're doing, and the range of support and ways people can access stuff. If you're able to give us some information, we're also happy to chuck that out through our monthly newsletters, so people are aware about where they can get signposts to, or where they can actually present themselves to as well. So anything we can help on that, please give us a shout. But obviously, I'm happy to drop you an email and say, these are the dates that newsletter goes out. Will be great. And then I suppose the final question, you might not be able to answer this, I don't know, but under point 16, there's that, again, I'm like you, I'm very visual, the chart about the diagnosis rate. Now, obviously, it's good to sort of understand where like the east of the city, the east of the county and the west of the county sort of fit. Is that able to be drilled down further? Because I just thought it gives you a bit more of an understanding about, rather than just clumping, say, the east of the county together, you may go, well, actually, where we're seeing less take up of maybe people going for diagnosis is here.
Yeah, so that's some of the things that we're going to work with ICBs on, really homing in terms of geographical location. Where is that? So then we can target the resources to really support and encourage. And I think a lot of it is about what you just said: marketing campaigns, comms campaign. We're going to do a whole campaign around making sure that everybody knows about this service in order to uptake it. Not just the DSS service, it's also about all the other services that are available across the county, because they all add up, don't they? And we're all working in this space, and it's just making sure we align. Yeah.
Yeah, thank you. I think there's some really good work happening, and I think collectively as partners, that's really important, because that's the way we're going to tackle this. I think we need that two-pronged approach in terms of bringing those waiting times down for formal diagnosis and assessment, but also making sure that people are aware that they can access those other services pre-formal diagnosis. I think a lot of people kind of hold back, thinking I can only access these services once I've got the diagnosis or once my loved one has the diagnosis. And I think that balance is really important as we move forward.
Yeah, I agree, and I think there's other barriers to break down as well, isn't it? Because there are some cultural barriers to break down. So there's loads of things in the pipeline that we really want to address. So then, within the timescale that we've got, till 2028, we want to address some of those. So next year, we would have moved on a bit more, and then we would. Yeah, thank you.
Thanks, Chair. Just a couple of queries, if I may, please, Amina. There's talk in the report around prevention, and I wondered if you could just tease a little bit more on that side out for us, because of course there's a lot in there about diagnosis rates and support afterwards, but there isn't a huge amount on the prevention side. And the other aspect is at point 15, you're talking about 4,000 people may have dementia but don't have it recorded, which obviously delays everything, access, support and what have you. And you've touched on maybe a couple of things, maybe around cultural issues, but 4,000 people out of 10,500 people is an awful lot. Can you shine some light on why you think and what can be done to embrace those people, and the earlier we can get them into support and give them proper advice and care, then maybe we can reduce demand on services and make their lives a little bit better. Thanks.
Thank you. Just bear in mind that I've only had this for a couple of weeks. So in terms of I think there's got to be a lot of awareness raising. So in terms of prevention, early intervention, there's a lot of work around, talking about working with our public health colleagues to raise the profile. And again, it's just going back to what you were saying about, really enforcing that even if you haven't got a diagnosis, you can still access services. So really the comms and marketing is really, really important for us as commissioners to make sure the breadth and depth is covered. And some people are digitally savvy. So that's one cohort of people, but some aren't. So it's about trying to reach everybody in using different methods of communication and raising that profile. And what was your other question? Sorry.
Sorry, the one was around the 4,000 people that haven't had a diagnosis but do have dementia. How do we embrace those and encourage them into the system so that the right care and support is available to them should they choose to offer it? And I get what you're saying around the prevention, but I guess most people would want to delay the onset of dementia as much as possible. And of course, people with dementia use services, and the more we can delay it and the lower the demand on services, the better. So maybe in terms of thinking about it, prevention might creep up the list slightly. I don't know. That's a debate for collaborative sake.
I try and answer some of that as well. So I think partly the prevention piece, as Amina said, there's a lot around advice, information, guidance, making sure that people have got the right support when they need it, particularly in the early stages. Going back to Fiona's earlier report, work starting in terms of thinking about some of the wider determinants and how other factors lead on to people developing dementia symptoms. And I think that's very much in its early stage, and that is an area where we could do much more. In terms of how we increase the diagnosis rates, partly that goes back to the point I think that Kevin mentioned, which is getting a real understanding of where in the county particularly there are issues, and it might not be equitable across the whole of the county. Or so this data in here is based on sort of East Leicestershire, West Leicestershire. It just goes back to the old kind of CCG days, which NHS data is still, some NHS data is still on that kind of footprint. Whether we can get down to primary care, this is built up from individual GP primary care data. Whether we can get down to that data, that would be helpful, I think. But obviously there might be some sensitivities in that because, you start getting into identifiable data if you're not very careful. But certainly when we looked at this previously and when we wrote the strategy last year, there was a particular issue raised around the fact that at that point, all the memory assessment services were based in the city. And there was therefore an issue of whether or not there was equitable access across the whole of the county, and particularly the more rural areas of the county. That's part of the change that we're trying to make in terms of bringing together the integrated service so that we can have those clinics out in different areas of the county. And that hopefully will make things more accessible to people and will hopefully start to address some of those issues.
In terms of that data, I know that Janine, as part of the sort of population health management, is trying to look at how we can break that down and build it back up in a way that makes more sense, because it is at the moment sort of presented in the historical way from the CCG days, and we now need to look at that slightly differently. So that work is happening as well.
Thank you. Conscious of time, so we'll have to move on to the next agenda item. So I will, hopefully I'll get it right this time. I will acknowledge the progress made since February 2025, endorse the continued collaboration to improve diagnosis rates and reduce inequalities, and support commissioning plans that embed co-production, cultural competence and carer support with annual updates. Are we all in agreement? Okay, thank you. So agenda item 8, the next report is the neighbourhood working update, which is on pages 29 to 38. This report provides an update on the neighbourhood actions taking place across Leicestershire and the work of the National Neighbourhood Health Implementation Programme. This report will be introduced by Rachel Dewar, System Neighbourhood Lead, Integrated Care Model. Over to you, Rachel.
Thanks, Chair. So what I've done in this report is focused a little bit this time. We had a general update around neighbourhoods at the last meeting, so I've focused this meeting on the work that we're doing around the implementer site. But what the paper does give you the policy framework and previous decisions that have been taken. So referring back to the 2005 neighbourhood health guidelines, which were produced earlier this year, which talk about very much delivering more care at home or closer to home or the place that people call home, and improving people's access, experience and outcomes to ensure both better care delivery, more integrated care delivery, but also reducing pressures on some of our acute services and ensuring the sustainability of both health and social care delivery. We also had the Fit for Future 10-year plan for England, which was published in July, and that talks very much about the shift from hospital-centric care to community-based care, embracing digital technologies and prioritising preventative healthcare. And then in July, we were invited, all ICBs were invited to take part in the National Neighbourhood Health Implementation Programme, which is seen as a bit of a fast track, supported fast track. It doesn't come with funding, but what it does come with is a programme of support from the national team to help us to really grasp what working in neighbourhood means and how we can progress faster first in terms of addressing some of the changes that we need to change. And that's around learning together, tackling challenges, delivering improvement, and also the OD elements, so the organisational development issues of working well in partnership. I think it's really important to state that this isn't a new concept. So we've been working in neighbourhoods across the county for a number of years. We've got really well established integrated neighbourhood teams, and they have their own health and wellbeing plans, which are based on local need, priority and assessment of public health data in terms of what are the priorities within that neighbourhood. What we don't have is consistency of approach and an understanding of what acceptable variation looks like. And what we haven't had is a really robust multidisciplinary team which have done proactive work, particularly with a higher needs group, which is what the programme this year is very much focused on. So we look at patient needs groups, and there is an ask that we focus on patient needs group 9, 10 and 11, which is those patients with the highest levels of need, but also that we continue that preventative work. So locally, we are very much looking at what does that MDT structure look like, and how do we create a relationship between that MDT structure and the existing integrated neighbourhood team structure, so that eventually that can become one. But in the meantime, there's a strong relationship developed between them. The focus is very much about bringing that care closer to home. It's very much around local engagement and involvement with healthcare, but also all of our support organisations, and also a really strong focus on patient activation. So people taking responsibility for their own healthcare needs and their own response to exacerbations in their healthcare needs. So the appendix to this report provides our short story about what we are focusing on in West Leicestershire, which is our national implementer site. But it's really important to say that the learning from the work that happens in West Leicestershire will be rolled out across the whole of the county, as well as City Rutland and our 2 new places which come under our Northamptonshire cluster. So why have we focused on respiratory and what particularly are we focusing on? So we have tried to create a scenario where we're not trying to boil the ocean. We are not looking at hundreds and hundreds and hundreds of patients and trying to fix everything for everybody. We started off looking at a frailty umbrella. We identified that the number of people in that cohort was really high, and monitoring the impact of the work that we were doing was going to be really difficult. So working with the Federation leads and other partners, what we decided upon is that we would focus our initial work on COPD, and that would be particularly with a patient who have got a diagnosis of COPD who are also housebound, but also those people that have been readmitted within 30 days of a hospital discharge. And the reason that's really important is there's a really strong link between an individual's mortality and readmission rates. What we've identified is that there's 504 patients across West Leicestershire who meet the criteria of COPD diagnosis and housebound. Each of those patients averages round about 11.5 prescribed medications each. Of those patients, each averaged an attendance or admission figure of 2.5 attendances or admissions in the last 15 months. So we're looking at over 1,000, so 1,260 attendances or admissions that we think we can significantly reduce through the work that we're going to be doing in that area. 7% of that cohort are under 65, 65% of them are between 65 and 84. And only 43 of those patients have had a COPD review in the last 12 months or since April this year. So our programme will absolutely look to increase that. 64.3% of them have had a flu vaccine in year. We would look to increase that, and 53% of them have are acknowledged as having a good inhaler technique, which leaves 47% of people who are needing further guidance or support in terms of inhaler techniques. And we know that that's a really important factor in terms of managing exacerbations. So we would also look to significantly increase that number. I've listed the background papers that are available, and there's links to that within the report. And then there's a slideshow which just talks about why respiratory illness and the focus on that is important to the NHS, but also to individuals and also to the wider system, and the kind of impact that breathlessness means to people, you know, which goes from being scared to leave home in case they get wheezy and can't leave home, or don't walk much now, avoiding exercise, avoiding the activities that actually can help to reduce, prevent or delay the onset of worsening symptoms. It talks about the impact of respiratory illness on hospital, on the person, on society, financial, which is an area that we need to look at, and measurable returns and how quickly we can see those measurable returns. So the actions that we're taking is going to be around assistant MDT for each one of those patients, which will include the GP, the care coordinator. It will include the services from Leicestershire Partnership Trust, so the respiratory services or the senior nurses for complex care being involved in those reviews. It will also involve UHL consultants, and we are also working to involve DHU, which is our out-of-hours provider in that. Each one of those will have a significantly updated care plan, which will be a care contract really in terms of what the patient can do for themselves, but also what is the response that we will give to that individual at times of exacerbation, which infrequently will require dialing 999. It will be about exhausting all of those community pathways first. So we hope to have activated patients who know what to do when they become unwell. We look to increase the flu vaccinations and all of those other areas I've talked about in terms of COPD reviews and in terms of support with inhaler techniques, increased community support and increased joint working between communication between organisations. So we will very much have the MDT work happening, but what we're also doing is linking in with the integrated neighbourhood teams to say, please include respiratory as one of your priorities and look at things like Active Leicestershire, what are they doing? Housing, we know that internal air quality is a really important factor. We also know that some of the areas of West Leicestershire significantly suffer from flooding. So damp homes, what that means in terms of respiratory illness and the prevalence of respiratory illness. So all of those wider determinant factors, warm, safe places, and lots of the services that other people have talked about today in terms of our community offers. How do we make those really accessible to people? How do we communicate the importance of the proactive individual responsibilities, but also how do we work with people so that they recognise future exacerbations and what that might mean for them, and how they can help themselves to prevent those. So that's the work that we're doing initially in West Leicestershire, as I've said, but very much we will be working across the wider area as well. And then the final slide within that, I think it's the final slide, the last but final slide talks about our call to action and how we will enact the work beyond the MDT and the INT work, and how every partner and every organisation can support this work, and we can reach it across some of those groups that we've talked about today. So our particularly vulnerable groups, such as individuals with serious mental illness. So linking in with mental health care is a really important part of this. At the moment, this programme isn't covering children and young people. The reason for that is that in terms of identifying that cohort of patients at the moment, we need to do some work in our risk stratification tool to be able to identify those individuals. But very much in the future, we expect to roll that out to involve children and young people. I'll leave it there, but I'm really happy to take any questions.
Well, thank you. It's an excellent report and really good and exciting piece of work, actually. I'd be very interested to see how it pans out. I did have one question on the senior nurse for complex care. How would you manage to link them into the role? Because they're usually focused on more of a kind of district nurse kind of role. So how would that link into respiratory?
So there's two services that LPT have put forward in terms of contributing to the multidisciplinary teams. So district nurses are already involved in MDTs, and the senior nurses for district for complex care are also involved in some of the MDTs. What we don't have is a consistent approach, but we also have our specialist respiratory service. So at the moment, LPT are working through who are the best individuals to be involved in those MDTs.
I see.
We're working through how many there will be in each area, when they will be, how they will work, and how we can make those fit the limited resource that everybody has in terms of being in that space, but recognising the impact of being in that space in terms of some of the reactive work that those services are doing, and hopefully translating some of that reactive work into the more proactive work that will happen with that within that MDT space. So we haven't dotted all of the I's and crossed all of the T's yet, but we're working with all partners, and LPT are really heavily involved in that in terms of what they think the right response in those MDTs will be.
Thank you. I'll open the floor for any questions. John, would you?
Thank you. Thank you, Rachel. So I think, as we've previously discussed, obviously very much welcome the focus on neighbourhood working and the opportunity to work collaboratively across the whole place to improve outcomes for folk. And I do recognise that there's a bit of a difference between what's required for the national implementer site and the speed and the time scales that we're working to on that, and the wider work that we need to do across Leicestershire. I think there is some concern that this particular focus, whilst it may have an impact on winter, hopefully it will have an impact on winter in terms of presentations, both in primary and secondary care. But I think there's a bit of a concern that its focus is very much clinically driven and isn't necessarily representative of the kind of overall approach that wider partners might want to take to the development of neighbourhood working, building up from the neighbourhood base, and what then becomes more important. And it might be that, you know, respiratory illness is the thing that everybody wants to work with, but I suspect it might not. So I suppose that where I'm going to with this is that perhaps there's a need for a kind of a different strategic conversation to take place around what we think the needs of the whole place are and how we work with different sectors and different local populations to build up what's important in each area and what will have the biggest impact on place. Because whilst obviously, as I said, you know, if a third of admissions, which I think was said to me the other day, a third of presentations, not probably admissions, are down to respiratory, that might have a very, very, very large effect in terms of secondary care over winter. But it might not, in the longer term, have the impact that we want in terms of developing a more integrated health and care system.
Yeah, I absolutely agree. And I think it's really important that we acknowledge two things. One is that we've had a really early respiratory spike, which generally means we'll have a second spike. And therefore it's really important that we get this work up and running now to have any impact over winter at all. So that's the first point. But also I think the second point is this is a 10-year programme. So there's something about what are we doing right now in the here and now, but there's also that piece of work to do. And I have to say the work that we're doing right now in the here and now is being really well supported by yourselves in the local authority. You know, we've got some project support coming from them. Liz Carter's really heavily involved in the work that we're doing as well. And we're looking at those different roles, particularly around care coordination, local area coordination, social prescribers, who's doing what are the opportunities within that. So we are starting to do that wider piece of work, but I think the work of the wider neighbourhood board over the next few months needs to be around really identifying what are we going to focus on when. So what's our 1-year plan, what's our 2-year plan, what's our 5-year plan, and what's our 10-year plan? Where are we trying to get to? And what are the steps that we need to take in order to achieve that? And certainly, so we're trying to develop a proof of concept through the impact of the MDTs with the work that we're doing within the implementer site. But it absolutely won't be that condition that each of the different neighbourhoods are looking at. And Janine is working with public health and the local authority and other partners in terms of developing data packs, which each neighbourhood will receive, which will help them to identify what their particular area of focus might be. But I think there's something about recognising that we're kind of the first 6 months of a 10-year plan and being realistic about what we can achieve when and how we make this a proper partnership approach, whilst recognising, it was said at one of the national meetings, the NHS are not a very good partner when they're dealing with their burning platforms and firefighting. So there is an element of this work that needs to be NHS centric so that we can be a better partner in terms of the longer term plan.
Yeah, thanks, Jane. A very similar question to John's actually. So I think your answers sort of covered it, Rachel, because I was thinking the same as kind of we've identified a cohort of people, may or may not be the right cohort of people, but you know, it's there. And we're thinking about the specialist support we provide, and then we're pulling in the more universal, like the wider determinants of health work. But then sooner or later, yeah, we need to move on to other conditions. But I'm also thinking, well, actually, sooner or later, we almost can't quite identify a problem and go, right, we're all going to pile in that because the universal offer is the universal offer. So there's almost a piece of learning about how do we do that consistently and then bring the resources that we've got in an area to bear on an item. See what I mean? There's almost you need to establish what your neighbourhood working is and then adjust your priorities to work on your priorities to kind of deal with it as opposed to setting up something new all the time. But I think the way you've described it would then take that forward, wouldn't it?
Thank you, and thanks, Rachel, for the update. I mean, I was going to make a similar point to that which John and Mike have made, to be honest. And I think the opportunity to take stock on the neighbourhood approach generally is one that I think is really important, particularly as we build the whole neighbourhood approach for 10 years. It's a massive strategic focus for local government, for NHS. So really supportive that we do take stock and recognise we've had this conversation before, and you've made the point about the need to align what's an acute intervention and almost a proof of concept, learning by doing that you're describing now with the existing architecture and try to bring those two together. So I think we're all on the same page on that, which I welcome. My particular question on this item was, you mentioned housing being a key factor around damp and mould and respiratory conditions. Have you got the connections and support you need with services and housing to make sure that people are contributing in the way that you're requiring for the MDTs?
Yeah, so early days on that, but what we do know is that our housing services are really well integrated into our integrated neighbourhood teams, and they are a key player within that environment. So that's the environment that we will be working within, rather than doing something new and different. We really want to engage those INTs in that work, so that housing is one element of that and a really important element of that, but it's also about all of those other services, about being active in spite of breathlessness and all of those other parts that from a preventative perspective we think will have a really strong impact, that impact will be over a longer time scale. But it's really important that we start doing that, because what we need to do is address the current population that we have, but also reduce the number of people that are falling into that PNG group 9 to 11 in the future.
Thank you, Chair. Thank you for the presentation and the update. So Claire Fuller, one of the key national leads for the NHS and focusing on primary care, said at the weekend that if you could distill the 10-year health plan into one sentence, it would be trying to deliver as much care as you can outside of the boundaries of acute hospitals over the next 10 years. And I see the pilot work as very much the first step in delivering that. So focusing on an area, focus on anticipatory care and moving as much of that outside. However, we know, as John said, and I agree with John, that a lot of the work that will support us in UHL isn't actually delivered by NHS or care organisations at all. It's the work that Kevin and his organisations can bring. So if we look at the work we want to do with neighbourhoods in the city, albeit a different local authority to this one, it's around supporting those who attend the emergency department over winter with no diagnostics, no tests and no medical clear need. If we could help those people find an alternative route for their support rather than the emergency department, that would free up significant space for us over winter. That isn't actually a health intervention those individuals need. It's many of the organisations Kevin works with. So each place will have its own characteristics and requirements, many of which won't need NHS resources. But I see this pilot, John, as very much the first step of a formal way of delivering on that 10-year plan ambition from the centre. But we shouldn't lose focus on the other bits that we're doing whilst we deliver that bit, would be my view. Thank you, Chair.
Thanks. And that leads me very nicely, thanks, Simon, onto my point is that I'm getting really anxious about all the different plans and strategies that are being evolved throughout the county in particular to tackle basically the same sort of health and well-being. We've just spent over a year revisiting and reviewing the Health and Wellbeing Board strategy, and key elements of that actually reflect in the 10-year plan. But what I don't see is the 10-year plan, and when we're talking about it, being linked back into the health and wellbeing strategy as it's being revised. And I think that's absolutely key, because what we don't want to do is duplicate anything. We want to make sure our communities are supported, we build up that resilience, involving the voluntary community, the district councils who have a major part, or both have a major part to play in all of this. And I think we're in danger sometimes of just, as you've alluded to, Rachel, firefighting, because there's an urgent need across this winter to protect the A&E and the hospitals, rather than thinking more broadly and longer term about making sure that we use the Health and Wellbeing Board strategy as our template and feed the other work from there, or at least cross-reference it into, because all the elements are there. We just need to tease it out in the right order at the right time. So I think, I'm really conscious that we're talking about this strategy, that strategy, but actually it should be one strategy with the key arms coming out. So that's just really an observation, not a question. Yes,
absolutely, and I don't disagree with you. So we are expecting in the next couple of weeks for the model neighbourhood plan to come out. I think that will help us with some of that, and I think that one of the asks within that will be that as an addendum to the joint health and wellbeing strategy, we create a neighbourhood plan that sits alongside and as part of that. Now our job on that is going to be made a little bit easier, because the work that we've been doing over the last few months in terms of the refresh of our joint and health and wellbeing strategy has absolutely linked to the 10-year plan and to the neighbourhood plan. But undoubtedly there will need to be something that is more explicit, as well as the implicit stuff that we already have within that plan. Moving forward, I wouldn't expect it to be an addendum. I would expect it to absolutely be a fundamental and integrated part of that plan. But it is really important that we align those strategies and the work that we're doing and the focuses that we're having to a realistic timescale, because we're not going to do everything in the first couple of years. So what can we do, and what can we learn quickly that will inform some of those priorities that we set?
So I've changed the proposed motion slightly, taking into account what we've been discussing. So I propose that the board supports the work of the Implementer Neighbourhood site and recognise the commitment to roll this out across the whole county, as well as recognising future priority changes. Can I have a seconder, please? Yep. Okay, all in agreement? Excellent. Agenda item 8 is the Office of the Police and Crime Commissioner update, which is on pages 39 to 46 of the agenda. This report provides an overview of health-related activities commissioned, grant-funded or provided as part of the responsibilities of the OPCC. We welcome Siobhan Peters, Director of Strategy, Partnerships and Commissioning, Officer of the Police and Crime Commission. That's one hell of a title.
For
Thank you.
Leicestershire and Rutland.
Yeah.
Thank you, Chair. Thank you, everybody, for having us here today. So this is the first time that the OPCC have brought a paper to the Health and Wellbeing Board. We are mindful of our responsibilities in terms of what we commission impacts on health, but I would ask you to bear in mind that that is not our primary focus. When we commission, our primary focus is related to crime, criminal justice and policing. As your chair has said, this report provides that overview of what we have that we think are health-related, commissioned and grant-funded activities. Whilst a significant amount of what we fund in the OPCC covers the whole LLR-wide area, in this report I've tried where possible to highlight specific areas that are specific to Leicestershire and Rutland. So the recommendation is that the Health and Wellbeing Board note the report for information, and in noting the report, they identify areas where the OPCC delivery links in with the wider partnership of the Health and Wellbeing Board priorities and where joint working could provide greater benefits for OPCC priorities alongside your own priorities, and note that the OPCC commissioning priority for 26-27 is the recommission of domestic abuse and sexual violence services for the commencement of April 2027. I would like to add here that since I wrote and submitted this report, members will be aware that there have been significant steps around PCCs and the abolishment of PCCs. So we are currently awaiting legal advice on what our commissioning post 2028 would look like. So we are still going to do our victim needs assessment and carry on with those things, but we are at this point not sure what our commissioning landscape will look like post 2028. So just in terms of this being the first report, I would bear in mind that as commissioning and grant funders, the OPCC has two statutory responsibilities, and they are to support victims and witnesses. So we provide victim support services for all crime types and specialist victim services for domestic abuse, serious sexual assault and rape, which we refer to as RASO, and we provide specialist support services to secondary victims of things like indecent childhood images, where a perpetrator has been removed from the family home, and we offer that secondary support to families and children in the home. And then all services are provided at age-specific levels. And our second statutory responsibility is the prevention and diversion from crime. So we provide commissioning for all out-of-court resolutions that are used by our police force that are an alternative sentencing option. We're currently out to procurement for those. We provide crime prevention advice and specific crime-related problem solving and grant funding to our grassroots organisations to deliver crime prevention and diversionary activities. So in the background to this paper, this report summarises the activity of the OPCC, which contributes to the strategic areas of the Health and Wellbeing Board. I'm going to start off with our drugs and alcohol support. So the OPCC makes a contribution of £111,856 per annum to the county's substance use treatment service provided by Turning Point. We make a similar but slightly elevated contribution to the city's mainframe substance misuse, also provided by Turning Point. However, in the centre of that, the OPC singly funds a drug test on arrest facility, which is based in the custody suites, mainly at Euston Street, whereby offenders that present with trigger offences, which are typically, but not always, acquisitive crimes, are tested by custody officers for use of Class A drugs. Those with a positive test result are offered a treatment intervention by Turning Point through the required assessment process.
I've provided a map here. You can see it looks like there's nothing goes wrong in the city and it's all green. It isn't. It's just that in order to produce this so that it had the data for Leicestershire, we've just blanked out the city. So there's no city information in there. And our areas may not look similar to your areas because all our areas are aligned to police beat areas, but there's a significant overlap. So the acquisitive crime across that sort of like the last year, 2025, 24-25, and as I say, not all acquisitive crime requires a drug test on arrest, but where it does, those people will referred on. So the main county areas for reported acquisitive crime are Enderby and Narborough, which includes Foss Park, Loughborough Town and Hinckley Greater, and the recorded number of police referrals to our drug treatment services across the year 24-25 were 325 referrals via the drug test on arrest, which includes those required assessments that take place within custody suites and any voluntary referrals, and 16 referrals via our young persons community resolution pathway, and those are young people who were referred into treatment either following a turning point or police intervention. Which takes me on to our involvement in youth justice boards. So the OPCC contributes just under £78,000 a year to Leicestershire and Rutland children and young people's justice services, and the OPCC provides a representative to that local board to act as a victim lead, which is also me. And there are health and wellbeing implications in sort of like youth and criminal justice services, the main being the provision or as is the situation at the moment across Leicestershire and Rutland, the lack of speech and language communication needs. And the Royal Society of Speech and Language Therapists identify that over 60% of young people in justice settings have some kind of speech and language or communication need. So we are currently working with the city and county young persons justice services to try and fund a speech and language communication needs post that would work across those services. So it would be one post that worked across LLR. A significant amount of that work would most likely be with other professionals rather than directly with young people, but it would be with other professionals, training our police officers, training other professionals in how to work with young people with those specific communication needs. There is tomorrow morning, I'll be attending the Youth Justice Board for the county and Rutland, so hopefully we'll have an update on where that's up to. We are beginning to look at a piece of work around gambling harms. To be fair, Leicestershire as a county are much more well advanced than pretty much anywhere else in this area is. So we're relying heavily on sort of like Leicestershire and the work that's already been done to date in the county. So the majority of crimes that are committed by those with gambling harms sit around fraud and embezzlement, and they are most often subject to custodial sentences. And gambling harms were from April this year subject to the public health levy, which is a mandatory fee on gambling operators to generate significant ring-fenced funding that's got to be spent on research, prevention and treatment of gambling related harms. And it places the voluntary industry contribution, it replaces the voluntary industry contribution, which didn't work very well. And it's aiming to raise over £100 million annually. These funds will be split with 50% dedicated to treatment services within the some within the NHS, 30% to prevention and early intervention, and 20% to research. Gambling harms have a broad impact on the individual families and communities where you're considering things like housing, finances, family breakdowns, and the impact of suicide is a significant factor. For every individual gambling at harmful levels, 6 to 10 other people are impacted by their gambling, which amounts to between 10,500 and 17,500 people in Leicestershire being affected by somebody else's gambling. And it's estimated that over 9,500 children live in the same household as an adult who might benefit from gambling treatment and support. So it's a piece of work that we are starting. The OPCC commissions FREVA to deliver medium and high risk support to victim survivors of domestic abuse and sexual violence. This includes the IDVA, which is the Independent Domestic Violence Advocates, ISVAs, who are Independent Sexual Violence Advocates, and CHISVAs, which are Children's Independent Sexual Violence Advocates. And in the next financial year, we will be introducing ISACs, which are Independent Stalking Advocacy Caseworkers. We will be introducing them. There's so many acronyms in that. We'll be introducing those initially by training some of our IDVAs to be able to provide that ISAC support, but that will only be that someone will get specific stalking support if it's related to a domestic abuse ongoing or previous incident. We are looking at how we can bring independent stalking advocacy to those whose stalking is not related to their domestic abuse, but that stalking in particular has significant mental health impacts on people. The service does work across the general population, but we do fund some ISVAs that support very specific groups. So we have specialist ISVAs and ISVAs that support male victims from Black and multi-ethnic communities. So it works in a much more culturally sensitive way. Victims from the LGBTQ plus communities and those with neurodiversity. We're aware that domestic abuse has a significant impact on GPs, on emergency services, including A&E, and on the county's mental health services. All our services focus across the whole LLR area, and while some of the ethnicity demographics are less represented in Leicestershire than the city, the county is much more prevalent of domestic abuse in rural communities, and work that went on in the North Yorkshire PCC area identified that domestic abuse lasts on average 25% longer in most rural areas due to isolation and various other factors, meaning that exiting abuse is much harder and takes longer and is much more complex for rural victims. So there are significant additional barriers to those victims than there are in urban areas. So we're trying to do a little bit more focus on supporting, because it's kind of like seen as a bit of a poor relation, I think, but we are looking more at our work in those rural communities. We fund Victim First, which is provided by Catch 22, and that delivers all support to all consenting victims of crime. So that can be anything from bike theft on upwards. And that also includes the standard risk of domestic abuse victims across LLR. They offer emotional support, practical support. We have programs called Young Futures, which is for teenagers. We have support which is specifically directed at young children where there's been, particularly around where there's been home invasion or burglary, and where that's got significant impacts on the mental health of children. They do support online, they do support in easy read formats. We have British language line support, we have web chat, and there's face-to-face support. And with regard to like a health lens, the service supports victims of assault and violence against a person, which have obviously implications for yourselves in terms of emergency, primary and secondary health providers. There is a little sort of like map there of the violence against a person for 2025. And the highest number of violence against person incidents across the county are in Hinckley Greater, Market Bosworth, Whittick and Ibstock, Loughborough Town and Loughborough North police beats. And across LLR in 2025, for all crime types, 10,459 victims were positively contacted, and 1,397 of those chose to decline support, but 962 engaged in some sort of support through our Victim First service. One of the other things that the OPCC is we co-commission the sexual assault referral centres alongside our colleagues at NHS England. So there is the East Midlands Children and Young Persons SARC, and they're located in Nottingham and Northampton. So children from Leicestershire in need of specialist forensic SARC services will go to those facilities, because children's services need to be led by a consultant paediatrician and adult services don't need to be led by a consultant, that is. So they'll generally attend the SARC which is closest to them. Our adult SARC services are delivered from Juniper Lodge, which is over in New Parks. It used to be New Parks Police Station, and it's gone undergone major refurbishment. Most particularly, very recently, we just spent another £250,000 because there is a new forensics code that's coming in about the collection and storage of evidence. So we have a one-way system through now that means that we can meet those requirements. The data on our victims, we don't break it down in the SARC because we don't want to do anything that's identifiable to people. So we don't ask for our data from the SARC in terms of sort of like areas. But Juniper Lodge over the past 12 months have received 341 referrals. They've conducted 167 forensic examinations, which therefore can then be used in court proceedings. If a victim survivor does not wish to proceed directly to court, through our evidence handling, we can hold that forensic evidence for 2 years. So it gives victim survivors an opportunity that later on the line, if they want to bring out a prosecution, they can. Because for most times we find that our victims, it's not the primary thing on their mind. But if we've got that evidence stored, then that's a prosecution that can come later down the line. The SARC has made 96 onward referrals to mental health teams or crisis teams and 50 onward referrals to substance use treatment services. The SARC offers and started 29 cases of HIV PEP and delivered 61 emergency contraception interventions and started 48 Hep B schedules. And we made 104 onward referrals to our sexual health services. So there's a map there which is of our rape and serious sexual assault map by policing beat, which excludes the city. I would say Whitwick and Ibstock and Enderby and Narborough are the areas with the highest reports of RASO. However, if a location is not known or not reported, it defaults to police headquarters as the address, which is in Enderby and Narborough. So that's a little bit misleading in the fact that there aren't that many rapes and sexual assaults happen in that area. It's just because of the way our reporting systems work, that's our default address. We are progressing the delivery. We worked with our sexual health colleagues about kind of like how they would like information for when people have been raped or seriously sexually assaulted. And we were talking about all sorts of various kind of leaflets and things like that. But what we are doing, because this is the advice that was given to us from our sexual health colleagues, was that they would like something that was like an animated video. So the video is the same. It gives all the information, all the steps that you need, but then there will be opportunities to have that voiced over in multiple different home languages. It's something that can be WhatsApp to someone with the appropriate language, and that will also sit alongside our written information. All our written information has been co-produced by victim survivors of rape and sexual assault. We're just revisiting that at the moment and adding a little bit more in about the court process and kind of what the expectations are, because the current expectation on rape cases is it's taking on average around 4 years to come to court, which is having a significant impact, and it seriously impacts that attrition rate. It's more impactful where we have children who were victims, because we end up having children that were sexually assaulted. We've had one case recently where the young woman was 12, but by the time she came to give her evidence, she was 20. And therefore that has a significant impact on how the jury sees a case, because they're not seeing a 12-year-old, they're seeing a 20-year-old, and it doesn't always get the results that we would like. We also, the OPCC also sits with the VRN, which is our Violence Reduction Network, and they work to a public health approach about violence, particularly in that under 25 demographic. And there's one specific piece of work that they do, which sits in the emergency department at the Royal Infirmary and the custody suite. It says here in Euston Police Station. However, we are moving to vulnerability suites for anybody under 18. We'll be moving over to our Keyham Lane custody suites, which has happened from November, and in the near future we'll be moving all females who are arrested over to Keyham Lane as well, so that no child or female will be in custody in the same environment as adult males. The custody suites over at Keyham are much more child, so we're working on, we've got a new child-centred policing project, and they're much more child-centred. They're painted more nicely, if you can paint a police cell more nicely. They've got chalkboards, we've got weighted blankets, so it's much more about trying to work with young people in as good a custody environment as we can provide, being mindful that it is still a custody environment. But the VIP project uses those like reachable moments in those settings, engaging with a young person at that critical point. They're in there because they've been attacked or they've been arrested, and we'll often find, particularly with victims around knife crime, that the victim and both victim and perpetrator at the same time. And workers continue to support sort of like young people long past their sort of like discharge from hospital or release from custody suite. They offer them mentoring and assistance. They look to achieve their goals. There's more information in the annual report of the VRN that's linked in this report. And then we've talked about it earlier, the OPCC co-commissions with public health in the county and the city, the Bereaved by Suicide Service, which is governance sits within Leicestershire City Council, but it serves the entire LLR footprint. And the service provides counselling to all those affected by suicide. We know one of the primary drivers for suicide is being impacted by the suicide of another person. In the last financial year, they received 79 referrals, 57 of which originated in Leicestershire. On average, 86 of those receiving support are white, and of those receiving support, on average, 21% are the children of the deceased, 20% are the parents, and 20% are the spouse or partner. And 13 are the parent of the deceased. So there's a significant kind of like cross-section of people who are affected by that. Just a little bit on our sort of consultation. It's where applicable, we do consult with the public or representatives of the affected demographics or community we're working with. As I said before, all our work that we have done and the literature we produce is produced alongside a group called Voices, which is a lived experience group who are victim survivors of rape. And last year we introduced a lived experience strategy, which includes representation from the public or represented groups when we are doing any procurement. So at the moment, through our out of court resolution procurement, when we come to do the evaluation of that in January, it will include people with lived experience of being on the receiving end of a out of court resolution and representative from people whose crimes were resolved through an out of court resolution. I'm happy to take any questions.
Thank you. Really fascinating report and good to see it here. I was just thinking at was it Whittick and Ipswich seem to have a correlation between the RASCO referrals and violent harm? I'm just thinking, is there anything that, again, sorry, Kevin, but Kevin and his organisations can help within that location, because it seems like there's some maybe underlying trends in that location that are leading to more sexual and violent assaults?
I mean, I can do a shameless plug for our current ground round, which I think you're aware, because my team came.
Well,
My team came out to you on Friday, didn't they, to do a presentation. So we have reworked the way that we have the commissioner makes available a certain amount of funding per year, which is for grassroots organisations, and we have now reworked that into supporting the 6 forward-facing areas of the police crime plan, and started on the 1st of December is a funding round for grassroots organisations working with violence and vulnerability. So they have to be smaller organisations that have an FTE of under 30. It's £10,000 for over a year, and I know my team came out Friday morning to your team to present about it, so that we are trying to sort of like ensure that we're pointing in the right direction when we're asking for those applications.
Thanks, Chair, and thanks, Siobhan. It's fascinating. There's obviously a lot of good co-commissioning, which obviously I know about, which is great. Sort of, again, a bit of a leading question. I was going to ask you, is there anywhere that you'd want to go next in terms of taking things forward? And initially I was thinking it's almost like the data around how many referrals are there from the police into services. Can we do more collectively to it's almost like make every contact count sort of thing, isn't it? And then actually I was thinking about the previous agenda item, and it's kind of John's point and picking up on Kevin's point, at what stage, I'm thinking of bringing it off the board and sort of look at Rachel as well. It's like you've got police around that table as well, and you almost build up that kind of, it's not a neighbourhood health model, it's a neighbourhood model. So any of those points you want to make a comment on, but so both in terms of tactical things we can do to further those links, and then maybe more strategically about where that kind of neighbourhood way of working goes, bringing in the INT previous conversation.
I think from our priorities that we're working on at the moment, probably the most tactical things around the gambling harms, but we are linked in with Joe and people here. And then in terms of all our neighbourhood teams, neighbourhood policing, are based out in neighbourhoods. So, for example, Belgrave are in the community centre there, and I know there are initiatives that go on, and it's probably well worth us having that conversation about, because I know they do, some of those neighbourhood teams do one-stop shops. So it would be an opportunity for health colleagues to be involved in those, particularly in areas where we are trying to increase reporting around certain crimes where there's a cultural sensitivity to it. So in those areas where domestic abuse we know is underreported, for example, if we look at, forgive me, I don't know the counties, but I know this issue because I was having a conversation about it the other day. If we know in the city that of the 10 extant DHRs, over 60% of them are women from an ethnic background, and above that, I think it's 55% are women from particularly the Sikh Punjabi population. We also know that 20% of our reporting of domestic abuse comes from that same population. So there's a massive disconnect between the reports we get. We're almost knowing about it when it's too late, when it's actually come to the worst part. So I think having health in those one-stop shops would be really helpful in order to, it doesn't mean then that people have to come and talk to the police, because they don't necessarily also want to talk to us, but if there's that health there, it's a bridge.
Yeah, completely agree. I think the one-stop shop And that supermarket approach where you go to a place for one thing, but then see something on the shelf that actually fits your needs as well, and you can pick that up while you're there, it is absolutely the place that we want to get to. We do have some of the community officers as part of our INTs currently, and we've also got some really good previous practice. So the Braunston Blues and Twos was a really good piece of work that I think we can learn on in our neighbourhood spaces, and again bridging that MDT INT approach, just thinking about how we make sure that following incidents of crime people end up with the right support and in the right place, where they're going to get the most appropriate response, but also about when does the patient come to health, when does health go to the patient or the person or the individual that's been affected by a crime, and bridging some of that work so that actually the person's not just seen, but they're seen in the most appropriate place by the most appropriate person. And I think that's a piece of work that we'll definitely want to explore as we develop our neighbourhood model.
Yeah, thank you. Mike's rather stolen my thunder because I was going to make a very similar point, but it sounds like we're in violent agreement. So firstly, just to say, really welcome the OPCC's report here. It's the obvious links between the work you're supporting and leading on, and health and wellbeing is absolutely clear. I think just to build on the point about neighbourhoods, so you touched on the uncertainties around the OPCC. Clearly, there's local government reform. There's also the transitioning of ICBs as well. So there's a lot of flux in the system. We should describe it as that. But we also know there is lack of co-terminosity in the system as well. So you mentioned around existing policing boundaries are on certain footprints. We have community health and wellbeing plans. We have INTs and other things that don't quite match. And I just think in a period of disruption and change, now is the time to be contemplating these things across the whole system and thinking about how we build something that's going to be sustainable, whatever the future of larger structures looks like. It's important we get the neighbourhood footprint right, because that needs to work whatever the future looks like, certainly in terms of local government. So I'd really welcome that strategic discussion, because now is the time to contemplate it. And the more we can build, the more we have common footprints, the more easy it is to work in partnership and understand each other's worlds and then build integrated services. And that's the golden ticket, which is easily said, but very difficult to do. So the more we can work towards that across these thematic agendas, the better, as far as I'm concerned. Thank you, Chair.
Thanks, Chair. That kind of leads on to the point I wanted to throw into the mix, which is a slightly broader one from a policing side concept. But you've heard today a little bit about the health and wellbeing strategy refresh, and part of the strategy, the revised strategy, will be about building resilient and confident communities. And of course, that's a key element in terms of policing, and community safety partnerships have that as one of their core aims. And I know you'll be familiar with the broken windows theory, that if an area looks run down and nobody cares about it, then it'll just spiral downwards, which leads... It's exciting, which kind of leads into feeds into a community where anxiety, mental ill health can grow and can fester away. And the reality is that I think that sometimes we need to align ourselves a little bit more broadly to think about the policing element, which actually really contributes to that broken windows theory, making things better, supporting communities, which feeds into the health and wellbeing strategy. So my sort of throwback on top of the report is, how can the OPCC and Leicestershire Police actively contribute to the development of that kind of partnership where the integration is key, whether we are a unitary authority, two-tier authority, or whatever. But we're talking again down at neighbourhood level.
So in terms of the community safety partnerships, it's the OPCC that convenes the community safety partnerships, and we are the funders of the community safety partnerships. So we are able to have some influence in kind of like where we go with them. We've just CSPs haven't seen them yet, so I don't want to say too much until CSPs have had the opportunity to see them, but developed new problem profiles which will focus on the top 3 crimes in your area, and then that will be able for us to then bring in that sort of like more problem solving approach, and obviously they will be different depending on the location in the area. I think it's something, Fiona, to be honest, that we need to give a lot more thought to, because I come from here like sitting comfortably in my criminal justice background, but it's how do we then, you're right, and I before when you were saying, when Rachel was speaking about, we've got so many strategies, we all have, but ultimately what we want is thriving and prosperous communities that are able to support themselves in the best way that they can. So I think it's something that we do. I don't have an answer for you right now, but I think it's something we do need to consider much more.
Hi, it's just a comment. Thank you for your report. We really welcome you here today. But I just wanted to answer Fiona's question. We do have representation from OPC on the Staying Healthy Partnership, where we do have a commitment around communities, and we welcome your contribution to the delivery plan development at the next stage of the strategy review. So that will be really helpful. Thank you.
Right, okay then. Well, I will propose that the board notes the report, including the areas where the OPCC delivery links into the wider of partnership of the Health and Wellbeing Board priorities, and where joint working could provide greater benefits. I'll also propose the board notes that the OPCC commissioning priority for 2026-27 is the recommissioning of domestic abuse and sexual violence services for commencement April 2027. Can I have a seconder, please? All in agreement? Okay. So I think now we've been going just over 2 hours, so I propose that we have a 10-minute break and reconvene at 1:15. Okay, right. Welcome back. So our next report is agenda item 9, which is the Better Care Fund Q2, which is on pages 47 to 62. The report presents the Q2 2025-26 template report of the Better Care Fund. The report will be presented by Lisa Carter, Health and Social Care Integration Service Manager, Leicestershire County Council. The floor's yours, Lisa.
Thank you very much, Chair. So this is our Q2 report for the Better Care Fund. I'll just pick out some of the key highlights that I normally do. So in September, we were given the deadline of the 10th of November for returning our Q2 position. The aim of this report is very similar to the last report for Q1. It was to give progress and assurance against the 4 national conditions and whether they are being met, and a confidence assessment on achieving the metric targets, and an update on income and expenditure. So the main difference between this report and Q1 is that we've subsequently had the Section 75 come to the Health and Wellbeing Board and be signed off, which completes all of the things within our national conditions that we have to do at this time. That means they're all now being currently met from 1 to 4, which you can see in paragraph 10 of the report. I'll just move on to some of the metrics. It's worth saying that for each quarter, there is a lag of some of the metrics. So what I tend to do in the commentary is to include some of the year-to-date information to give you a bit of an idea as to how we are performing against some of our targets, where there is some of that indicator information missing for sort of 1 or 2 of the months of the quarter. So in terms of the standardised rate of admissions per 100,000 population into our acute care services, we are currently on target for meeting the quarter, which is July and August is what we've got data for at the moment. September data is not yet available. Year to date, we're slightly below the target. We've got about a variance of 2%, so we're just about 2% off the target. The discharge data is probably where we're not currently meeting our targets. We've got quite high targets, it turns out. So I've asked one of my BI team members to have a look at where we are sort of nationally. Where we are regionally, I'm not massively concerned because we're actually in our regional peers, we're actually performing pretty much on average or better than average across our regional peers, but we are still slightly off target. One of the things that we are, because I'm quite competitive by nature, I think we should still strive to reach that target. So I've been speaking to this week the strategic discharge group across LLR to look at including some of the activities and actions that will improve these discharge targets, making it part of their programme plan to do that, because we have to really do that together. These aren't just targets about discharge for pathways 1 to 3. These are targets that also include pathway 0 as well. So it doesn't distinguish between what is the responsibility of one half of the partnership and what isn't. So it's important that we kind of work on all of those together. Still not massively off target, and I'm not overly concerned that we couldn't pull that back by the end of the year. In terms of long-term support for the needs of older people, met by admission to residential nursing care home, actual data for this period shows that we're currently just about on target. Year-to-date performance is 421 admissions against a target of 434. So actually lower the amount of people, the lower amount of people that we have going into residential and nursing care homes is better. So we're quietly confident that hopefully this year we will meet that target too. The report also includes an update on the income and expenditure. You can find all of that information on the spreadsheet that comes with this report, and you'll see that in terms of expenditure, we've currently published around 48% of the amount has been spent. We try and aim for around obviously 50%, but at the moment it's about 48%. We are confident that we will spend all of our BCF allocation by the end of the year, and that's it. Thank you. I'll open up the floor for questions now.
No questions. That must have been in. Oh, there is now. Yes, Yasmin.
Is that 48% as at month 7, month 8?
It's 48% at the end of month 6.
That's fine. That's what I was. We're halfway through.
Halfway through, yeah.
Thank you. Great report, Lisa and Tracy. Question really not about Q2, but more about some of the media coverage around the future of the BCF. Is there any insight into what that meaning for us yet, or are we still waiting?
So the national programme have really been lacking kind of information recently. So the things that we had got planned to work with them specifically on helping them to shape it for next year, which puts us in a really fortunate position that they kind of like us to help them to do that. They've had to cancel those because they've not had enough of the direction nationally. However, we have had our finance updates for 26-27, so we know what the uplift amounts will be for that, and we know the proposed uplift amount for 27-28. So it's looking like, I know definitely that the next plan will be a year plan, unless again that's changed, but that was what has been reported in the last couple of months. But we do know that there's likely to be a reshaping more towards neighbourhood models, which we've kind of partially done already anyway. 70% of ours, I say this all the time, 70% of our BCF points towards community delivery as opposed to intermediate care or acute care. And we can proportion out already some of that work around neighbourhood models of delivery. So quietly confident that we're in a good position to do that. We do have a workshop that I have programmed in for the Health and Wellbeing Board members and the IE members and the IDCG members to work on the BCF delivery and deliverables when we know more. That's probably, I think it's the 27th of Jan. Yeah. 27th of Jan. It's likely to, it's always going to be slippage depending on the national kind of drivers for that, but because I want to give you as much information as we possibly can nationally, but we will be doing that piece of work then.
No other questions. Okay. Well, thank you. It was a very good report with not very few questions afterwards. So I will propose that the performance against the Better Care Fund outcome metrics and the positive progress made in transforming health and care pathways up to Q2 be noted. Can I have a seconder, please? Thank you. All in agreement? Thank you. Agenda item 10, our next report is the Send and Inclusion Alliance, which is on pages 63 to 96. This report provides a progress update of phase 2 of the work of the LLR Send and Inclusion Alliance. Faye Bayliss, Director, LLR Send and Inclusion Alliance, and Mark Roberts, LPT, will present the report. Hello again.
Testing. Thank you, Chair. So yeah, Mark is also Director of the Send and Inclusion Alliance, so we are sort of as one. Yeah. So I thought I'd start by setting the sort of context for the Alliance. So we, LLR, were the East Midlands representative of the National Send and Inclusion and Alternative Provision Change Programme Partnership. That is due to conclude in March 2026, but because we've formed such a great partnership across LLR, and the DFE have supported us to continue because we want to sort of stay working on these initiatives and embed them over the next several years. So that's what the Alliance is all about. Leicestershire County have already signed our Memorandum of Understanding, and as have other partners, so we are here to stay for a little while at least. So I'm only really going to focus today on, I think it's slide 3 in the deck, which is it looks like a leaf. And there's 5 strategic priorities on there. So I was just going to walk through some of those to really sort of set the context for the Alliance. So the first thing to say is co-production is the golden thread that underpins everything that we do. We've established a co-production group for our Alliance. We work very closely in partnership with our parent carer forums across Leicestershire and Rutland, and we've appointed a co-production lead for young children and young people who also chairs the regional Young People's Assembly, and she's working with Derby University to do some local research for us as well. So the next thing to say is on the leaf that talks about the CPP. So the product this year, we're entering the final phase of the programme. The product is the local inclusion support offer. And what that means is the aim of it is to keep as many children as possible with SEND needs in mainstream education, because we know that their long-term outcomes will be better if that happens. So we're working very closely across the partnership to ensure that our alternative provision services are meeting need. We're doing some pilots around specialist task force, alternative provision. One of the it's capital funded pilots has been around assistive technology, and Leicestershire have really sort of led that across LLR. And from a health perspective, we've piloted PINS, which is Partnership for Inclusion of Neurodiversity in Schools, and LSEC, which is Early Language Support for Every Child. And those things, particularly the LSEC, we know that the size of a child's vocabulary at age 4 is one of the most significant sort of contributing factors to long-term health outcomes, particularly around mental health. And our LSEC service, we were one of the Pathfinder sites, and it's been very successful. We've seen nearly 1,000 children, and the vast majority of those have not needed specialist referrals after that. And these are early years children, so often preschool. And 100% of those children have been discharged with a really good satisfaction from parents and families. So we're really proud of that. What I particularly want to talk about our community inclusion offer, because it really did start here in Leicestershire. We actually branded it Shaping SEND Futures, and we've done some very targeted work with a couple of districts, Hinckley and Bosworth being one of them, because SEND was a priority identified within the health and wellbeing report, and North West Leicestershire. Some of the things that we've started to test there is social prescribing role for children and young people, so 14 to 18-year-olds, because exam stress is a real trigger for people, particularly with neurodiversity. That post has only been going 5 months, and already she's had 600 contacts with children. She's managed to get some fantastic case studies. One was a local young lady who'd been absent from school with social, emotional and mental health problems, and she's actually now got her back into school, walked through the door and gave the child confidence to have the difficult conversations with the teacher. So this is something that we really want to embed. And certainly in North West Leicestershire, we've just recruited 2 social prescribers, and one of them will sort of build on the learning from Hinckley and Bosworth. But the PCN Federation in North West Leicestershire have committed to including in all of their social prescribing role a focus on children and young people. So I think that should have a real impact going forward. One of the other things to say, and I was really interested in your report, Siobhan, because what we're finding is and I tend not to use the language of SEND actually, because I want to focus on additional needs more broadly. Because when we've been into schools, I've been to speak to head teachers of primary schools, and when I've asked the question, what are your biggest challenges around SEND, they've said it's adult mental health. Because actually the socio-economic circumstances, deprivation, domestic violence, poverty and addiction in particular means that the majority of children in his primary school have additional needs. So one of the things that we're really keen to do is work in a very aligned way with the Family First programme. So both the LISO, the Local Inclusion Support Offer, and obviously the Family First programme are focusing on the support available from family hubs. Now, one of the things that we have tested and sort of early on is that some families are reluctant to go to family hubs because of the stigma around social care. So actually we're looking at what we can do in libraries or other social spaces that don't sort of have that same stigma attached. So I'm really keen to follow up with you, Siobhan, after this. It'd be great to work together on some of those things. So that's the community initiative, and we've got a rollout plan now. I think we're going to Wellbeing, Wigston and Melton next. So we'll have the whole county sort of with these projects underway in the next 12 months. And we're having conversations across Leicester City and Rutland as well.
The next thing I wanted to talk about then, on the sort of fourth petal, is the aligned commissioning programme. And we're deliberately using the language of aligned commissioning because there's very little new money around to invest. But what we do know is that there's often difficulties in transitions across services. We've still got cliff edges defined by age and diagnosis that don't make a lot of sense to people. So we're doing a lot of work around, in fact, Mark is leading with his other hat on the through the LDA collaborative work on the ND profiling, because we want to be able to support families on a needs-based level rather than a diagnosis-based level. So all of this work is informing our joint commissioning priorities. As part of phase 1 and 2 of the CPP, we've really developed the local area inclusion plans. So we've triangulated that information across LLR. We've used our Young Researchers, Young Voices report, and we've looked at other, in fact, we've built a data dashboard, which we're still testing, but it's got health, social care and education data. It gives us a far broader intelligence around the young people that we're supporting. So all of that evidence has pointed us to 7 key priorities for aligned commissioning. One of them, the first one is mental health, that's screens, and it's particularly the sub-CAMS level. So many of these children aren't meeting the CAMS thresholds, and whilst we commission mental health support teams in schools, they will only see children in school, but we've got increasing numbers of children absent from school with social, emotional and mental health problems. So we're really interested in how these social prescribing roles and working with family centres is going to bridge that gap. The second priority is around coordination and navigation. So we have family support workers, care coordinators, care navigators, social prescribers, all have a slightly different function. So this is why we really want to look across the social care agenda as well as the education and health agenda to see what we can do to streamline some of that sort of signposting. Similarly with advice and information. Speech, language and communication needs is a huge priority for us, and I don't need to repeat what has already been said here, but we're very keen to commission something in a graduated way. We have speech and language support in schools and we have our therapists, but we want that bit in the middle as well. We want to make sure that we don't sort of allow people to drop off a cliff just because they don't meet a specific threshold. Preparation for adulthood is another one that came through as a clear theme, particularly so our post-16 offer and helping children into workplaces. And some of the pilots that we've done in Hinckley and Bosworth is actually a strong alignment and working relationship with local industry there. And in fact, we've recently had one of our young people graduate from the special school there with an apprenticeship at Caterpillar, actually. So we really want to sort of promote those sorts of initiatives working with local business. The last two joint commissioning priorities, there's one around integrated waiting safely offer. So we know that our diagnostic waiting lists are intolerably long, and as we've already heard, you know, with other waits across the system, the harm that can be done in that time is a real challenge for us. So that's why we're doing this work around the profiling tool. But we also want to make sure that families have got somewhere to go while their child is on a waiting list, and that is part of this family first alignment. And the last one is around transport, send transport. It's a real political hot potato around funding, but actually there's a number of children who are eligible for continuing care who will have transport in that bespoke package. So we really want to look at what opportunities might there be to commission transport on a broader level rather than just for individuals. So there may be some opportunities for efficiency there. So those are those priorities. And the final leaf on there is around shared ownership, shared accountability, which is really important. And we believe that if we do all of those other things, actually we will be more accountable. But I'm going to hand over to Mark here because he really has been the architect for the governance around our Send Alliance. Thank you.
Thanks very much, Faith. So a lot of this information's in the pack, but I'm conscious that there's a lot of information in your pack, isn't there? And we're 2 hours or more into this meeting. So I'll just give you a sense of this. And it's important to understand who's in the Alliance. So the Alliance is constituted from DFE money that's been allocated to local authorities and then has been channeled into perpetuating the capacity and capability for continuous improvement and development beyond that change programme partnership. And it includes the 3 local authorities, importantly the 3 parent carer forums, the Leicestershire Partnership Trust, the Integrated Care Board, and also the SDSA, which is a Schools Development Support Agency, which, as I've said before, sounds like a national body, but it's actually a Leicestershire and Rutland-based organisation that supports regional development of local authorities and schools in relation to SEND. That team effectively provides us with a view across a lot of different areas of work. We're under no illusion that we're going to be able to deal with everything, but our role is specifically to undertake delegated tasks, delegated from place-based partnerships, including the Leicestershire SEND place-based partnership. And those tasks are many of the ones that Faye's just described. So the joint commissioning strategy, specifically a community inclusion offer. And beyond that, as it happens, the CPP, which is all about testing reform ahead of the white paper, which has been deferred a couple of times. The school's white paper is due in January. And then anything else that is defined as a project which we feel is worth taking forward across the whole system rather than on a place-based model. That at the moment that seems to be taking good effect. There's the MOU is included in the papers. It gives both a sense, not just who's involved, but how they're involved. We're interested in developing the partnership further. Whilst we might have formal partners that are defined in that MOU, our board includes others who can positively contribute. And if we think conceptually about the alliance, the criteria for being involved in the alliance, being part of the alliance, is you've got a will to improve local services, the lives of children and young people with special educational needs and disabilities. That's it. And so we're really interested in how that might develop. We're particularly interested in research-related connections, the connections to our 2 universities particularly, although we can easily go beyond Leicester, DMU and Leicester for insight from universities, where others have done some really heavy lifting on that type of topic. But we'd like to invest our time and energy and develop those connections locally. We're very keen to make sure that our work is directed by a combination of research and data. And you've heard about the 2 elements of how we might do that, but also lived experience. We feel like we're stronger on the lived experience at the moment than the research. So that would be something that would be interested in, and a very wide range of insights in research. It's not one group of people, is it, often? So I think that probably gives you a sense of where we are. We are 4 months in. I think we've had 4 boards. So it gives you maybe a sense of what's coming. Open to questions. Well, we have
Thank you.
So we have a cheeky question for you.
All right, go ahead.
Well, our request, this board, when I came here for the Learning Disability and Autism Collaborative, perhaps a year ago, this board kindly agreed with a suggestion from me, which was to ensure that every paper that passes through this board is scrutinised with a consideration as to whether or not it improves access and support from that service or that strategy for people with a disability. It's a simple, single question, really. Now, theoretically, that includes children and young people with special educational needs and disabilities, but I'd suggest that maybe we want to re-clarify that, certainly include that group in that definition. That would be really helpful and welcome.
I agree.
Thank you.
Right, any questions? Yes, Kevin, please. Saw Kevin first.
You're too kind. Hello again.
Hello.
Sorry, this morning at the City Health and Wellbeing Board. Again, it's just basically to go on record here at the county one to say that we would love to be able to support you with the rest of the voluntary sector and how we can get them involved. Whether it's sort of helping you with signposting, whether it's helping you with groups actually understanding the provision and what's available and how they can get involved, their service users and the like. So again, if we can pick that up, that'd be great. And I suppose my other quick one was just hearing what you were saying there a minute ago, Faye, about the individual with the SEND needs getting into employment. I also, for my sins, now sit on the business and skills partnership. So I think it would be good, because there is going to be a discussion looking about skills and skills for the future, to, if you bear with me, to try and loop you into that, because I think, again, it'll be an important discussion to have, to not look just at the skills needed per se, but the wider issues around skills and maybe some of the barriers that some people may have to getting into employment.
That sounds fantastic, Kevin, and I'll definitely take you up on that offer, because one of the things that I'm really keen to develop as well is a kind of coaching model for people, you know, as they're sort of leaving school. We've tested some of those through Dorothy Goodman in Hinckley and Bosworth, and it's proved to be really successful in confidence building for young people. So yeah, it'd be great to work on that with you. Thank you.
Hi, thank you. So you'll have heard the neighbourhood presentation and kind of the infancy of that 10-year plan. But given the comments that you've made about where people are prepared to access and willing to go, that whole kind of supermarket model of the neighbourhood hubs moving forward, it would be really great to integrate the work that you're doing in terms of SEND and in terms of young people into that model. So I'd be really interested in creating a connection between the work that you're doing and the neighbourhood board.
Yeah, and thanks for that, Rachel. I've already met with Aruna Garcia, who chairs the board, and she's really interested in the work that we're doing. One of the things that we've found just in the small pilots that we've done is schools are actually perceived to be a very safe space for parents to go into. And what we're finding is the parents want to speak to the teachers, but the teachers aren't doing teaching. So we're finding that the head teachers, the deputies, the SENCOs are so sort of embroiled in parental support that they're not doing the teaching and the learning activities. And that's why we're part of the next round of the pilot we're doing is we're placing social prescribers in schools. We may not call them social prescribers because I think that term has its own connotations that families, you know, struggle with. So, you know, but we're working very closely with West Leicestershire PCN Federation on that.
Thank you for outlining that today. From a criminal justice point of view, we know that adults with SEND and learning difficulties and learning disabilities are disproportionately represented in the adult secure estate in prisons. I'm kind of wondering if there's things that we can do from a potential policing and criminal justice point, much further back down the river with children and young people with SEND that kind of, I know we're not going to like put the world to rights, but it stems that tide a little bit for some of those young people becoming those adults that go into the secure estate.
I'm pleased you've mentioned that, Siobhan, because this morning I shared my sort of personal reason for coming into this space. So my secondment is from the ICB, and I was responsible for personalised commissioning, and will have worked with John's team on some of the work on some of the joint funding activity, and we've identified the cohort of people, and we're talking about the same cohorts of people that present the greatest risk, but are also the most costly to support in the community, are 18 to 25-year-olds with learning disabilities and complex needs. Many of them the learning disabilities and complex needs, many of that develops into mental health. Many of those individuals have been through the youth justice system and are now costing often in excess of £10,000 a week because they've got 4-to-1, 5-to-1 support. So not only, and they're not living, you know, they're in, whilst they're in the community, they're isolated essentially. So it's not a great outcome for anybody, and it does place a huge burden on public resources. So I've come into this space to resurrect that work because we've actually started to do some deep dives on that cohort precisely to find at what point did it all go wrong? Where could we have had an intervention, either from health, social care, education or voluntary and community sector, to have actually just kept that individual in school, on track, because we want to prevent this going forward. I think doing this community work is where it's at in terms of sort of changing the tide on this.
Chair, could I just add, essentially, as Faye describes the space that we work in, and I think it's probably helpful to think of this on, we work in the space that's between all the other organisations. Really. We don't hold a commissioning budget of any description. And we inherited on the very first day of the Alliance being formed our own existential crisis, insofar as we got funding for about 2 years. And in about this time next year, if we haven't resolved that and evidence to the partnership that we're good value for money and we ought to be perpetuated in some form, then this will disappear again. But it is important for us to understand that we are working with the aligning of commissioning in the way that Faye has described, not commissioning with new money. Many hundreds of millions of pounds that are represented around this table is our budget. So it's effectively your budget being manoeuvred to our needs, really. And so that's our role and that's our focus.
Yeah, you can just take your microphone.
Yeah, cheers, Mark. It's homeopathic funding. You know, the less you get, the stronger actually is the impact. That's how it works. Right, what I was going to say. Extending the prevention bit, Siobhan's question, the more you go upstream, it reminds me we had that conversation a little while ago about neurodiverse friendly environments, and you know, you can only do so much at one time, but I just wondered if it was worthwhile saying something about that, and if there's been any moves. And I don't know, it's probably something that brings in my district colleagues, but I don't know, it's not so much a question and expect an answer going, why aren't you doing it? But I suppose it's one to raise and just think about where do we go collectively as a health and wellbeing board about really going upstream and pursuing that ideal idea.
I would say there's a lot of expertise available to provide advice and guidance from for any type of organisation, whether it's a cafe, shop, GP surgery, dentist, any organisation, local authority building, about what a neurodiverse friendly, appropriate environment looks like. And there's very good evidence to suggest that neurodiverse friendly environments are friendly for everybody, beneficial for everybody. We have more so in the LDA space, rather than disability and autism space, rather than SEND, progressed a series of benchmarking tools which people can access that they could then apply with some guidance into their space. For example, we have LD friendly GP practice awards in place, which are helping GP practices benchmark themselves. They could easily be reapplied into autism and other areas as well. And so that would be my sense of that. I think that's where we are. As we turn more towards our neighbourhood, you could call it a neighbourhood model, really, you know, and aligning with that type of work, then I think we'll start to see people generating their own tools, generating their own expertise in a sustainable way at a local level. And I think we realistically can provide the guidance, support and connections to enable them to do that.
Thank you. Yeah, I just wanted to say I really welcomed your presentation. To be honest, often when we hear about SEND, we hear about deficits, we hear about broken systems and failure and inability to meet the rise in demand. It was lovely to hear about some positive things that are happening actually, and that's really encouraging. So I really welcome that. Just to say, in terms of those connections, and Faye, obviously you'll be familiar with the kind of relationships around the districts and the role that we can play and the community health and wellbeing partnerships. So just want to make sure those connections are taking place. And when, as you say, you come to Melton, you'll be talking to my team and colleagues who I'm sure will want to help with this. So thank you.
Thank you. Excellent update. Apologies. I'll start again. Excellent update. I'm conscious you said UHL wasn't a member of your SEND Alliance. Is that an intentional, or we haven't decided to be a part of? Should we be a part of? I'm just conscious of the individuals that use our and access our services. Maybe we could be a better organisation if we were involved. But if it's not relevant, then I'm happy to. And now.
I think there is relevance, Simon, and certainly I've spoken to I can't remember the lady's name, but somebody who works in UHL that supports the cohort of people with learning disabilities. So we're sort of connected in loosely, but in terms of our objective in all of this, the central tenet is about belonging in communities. So we kind of, our focus has been on how do we keep people well. In my opinion, and my 30-year career in the NHS, this presents the best opportunity to move us from treatment to prevention than we've had before, apart from perhaps immunisation and vaccinations. But this is about trying to support people as they, in fact, you'll be familiar with some of the work we did around intermediate care, and we sort of developed the More Good Days model. And what we want to do is catch people as they start to decline so that they can stay in school, they can stay in their local communities, and the community is resilient to support them. And just to touch on Mike's question as well, in terms of the sort of inclusive neurodiversity, I can't say it, but you know what I mean, the inclusive spaces. So the PINS programme is all about that, and one of the things that we're keen to do after the programme is finished, so mental health support teams in schools, LSEC, PINS and many others work on the model of universal, targeted and specialist. And actually we're really developing a cohesive training offer and trying to reduce the duplication, because there's such a lot of duplication in our system. And actually there's something about how do we as health, education and social care define that universal kind of training offer. We've started in schools because that we're DFE funded at the moment, but actually the model could work in any environment really. So this is our ambition as we roll out the Shape and Send Futures programme and beyond.
I really welcome the comments about the move to acknowledging needs rather than a label. And I think that brings us all into the same space, because we recognise conversations where there isn't a neurodiversity label, and then one of the partners might say this is behavioural because of trauma, but they present in the same way, or it's something else, and the child gets trapped in the middle, isn't it? And for me, it's irrelevant what the diagnosis is or isn't, if they're behaving in a way where the environment needs to change and understand them, and we don't have the knowledge base, the training to do that. So I think my plea is, and we know a lot of our children who have experienced domestic abuse behave in ways that the behaviour is a symptom of what they need, and then we're not responding in the same way or acknowledging that. So I suppose to keep us in that environment where we are capturing all the children they need, it's not just talking about SEND children, because quite often the children who are our most expensive or are worrying don't yet have a diagnosis, don't yet have an education, health and care plan, and we're still trying to get to know them. So that space of addressing things early means we also need to be able to working with children and families before and without a diagnosis.
Sorry, Mark, precisely that, Nikki. And so the subtext to the mental health priority says and trauma and attachment, because actually it's how the issue manifests, isn't it? And it's about this the sort of and I've often sort of criticised the health model around sort of that diagnosis being the key that unlocks a particular pathway, because it's really unhelpful for families, because those services would absolutely benefit these young people. So we really do need to move away from that, and absolutely as an alliance we recognise it. And I think linked to Mark's point about we've no statutory responsibilities around commissioning, but what we want to do is make recommendations to the Mental Health Collaborative, to the Family First Partnerships. It's about how do we click into those established forums and influence the agendas that will support the same children that we're talking about in continuing care, in SEND, in LDA. There's lots of conversations happening about the same children, and I think it's part of our role as the alliance is to make that one conversation.
Thank you. I did have one question. A lot of parents feel that being in a special needs establishment is better for that child, that they'll get better outcomes at the end of it. I noticed you'd said the opposite at the start, which matches what I'm reading, but is there any work to kind of explain this to parents? Because once you start saying you can provide care in a mainstream environment, a lot of parents feel that they're not getting what they need, that it's not, optimal education.
I can try to respond to that. So the involvement of our parent care forums is key to this, really, and the way in which they're engaging the different families and the communities around these topics. Some of these topics are controversial, aren't they? Because those parents, their actual lived experience is the opposite of what our strategy suggests. And those are areas of tension that we have to manage as we progress, and convince them through a change in the level of support that they get in the mainstream environment that their child is well served there. So there isn't an easy answer to that, I guess, is my summary, but it's something that we're very conscious of.
Thank you. So basically what you're saying is they have a better outcome in mainstream if possible.
I'm saying that mainstream education needs to adapt more to accommodate the needs of children with special educational needs and disabilities, in order for those parents to feel more confident about the placement that they're in mainstream education, rather than seeking an alternative in specialist provision.
Right.
That will take time, really. And there's a parallel in this within neurodiversity and neurodevelopmental work, insofar as there's models which would suggest that we should really quite restrict access to diagnosis. But a much better option is to enable parents, families, children and schools to better understand neurodevelopmental needs of the child and better be able to meet them, and therefore have a reduced demand, a reduced desire for a formal diagnosis. But those topics are controversial, because there are also a group of parent and carers that believe that a formal diagnosis, rather than whatever the Equalities Act might say about meeting needs, it's the formal diagnosis that changed their life. And it gave them not only access, but a deep understanding of what their needs were, and validated perhaps their life experience. So there's very different models around the country. From Portsmouth, which almost exclusively excludes diagnostic pathways, all the way through to more scientifically orientated models for particularly early years in Manchester, which are developing through the age ranges that are a few years away from being complete.
Thank you. Right. Well, if there's no further questions, I will propose that the board notes the progress of phase 2 of the LLR Send and Inclusion Alliance and the approach to phase 3 and beyond, continues to support and work in partnership with the LLR SIA. Can I have a seconder, please? Thank you. All in agreement? All right. Thank you very much for your report. Agenda item 11, we now move on to the pandemic planning report, which is on pages 97 to 108. This report covers pandemic preparedness across Leicestershire and will be presented by Amina Chudasama, Head of Emergency Preparedness, Resilience and Response, ICB. Anuj Patel from Public Health is also here for this item. The floor is yours.
Thank you, Chair. Before Amita covers the report in a bit more detail, just to highlight why we're here. So under the Civil Contingencies Act and Health and Social Care Act, we're legally required to plan for, respond to and prepare from emergencies, and that includes pandemic. We learned a lot from COVID-19, and it showed us just how deeply these events can disrupt daily life, strain our health and care systems and widen inequalities, particularly for our most vulnerable residents. And effective pandemic preparedness is essential to protecting lives, maintaining services and reducing the disproportionate impact on those already disadvantaged. So over the past year, we've worked really closely with partners across health, local authorities, emergency services and the voluntary sector to strengthen our plans, test our response and ensure we're ready for improvement. Our preparedness is also integrated with the wider health protection and emergency planning work, and that includes vaccination programmes and business continuity work, and it's aligned with national frameworks, regional strategies that ensure consistency and access to wider support. So the paper will give the board an overview of our current position, our capabilities, the learning we've embedded and the ongoing challenges we face.
Thanks, Anuj. So just to summarise our current position, LLR partners, including the LRF, have participated in 3 pandemic exercises this year. We had exercise Tangra in April, which was the ICB-led exercise to look at health, focused on our capabilities within all health organisations and how we would respond during a pandemic.
We then had exercise Solaris in May. This was an LRF-led exercise, and this focused on local authorities, the voluntary and community sector, and how they would work and coordinate a pandemic response in conjunction with health. And then finally, we had exercise Pegasus at the latter part of this year through September, October and November. This is a national tier 1 exercise. So this is mandated by the government, and it brought together the Cabinet Office, all UK government departments, LRFs, health, social care, local authorities, emergency services and voluntary sector partners. And that was to test a full response, including national, regional and local response levels. Throughout the 3 exercises, we focused on some key themes. The first was resources. So what do we have in place locally? You know, PPE, fit testing capacity, delivery of testing and vaccination if we never needed to go back to that position. Workforce, what protocols do we have in place so that we can ensure business continuity, use of our voluntary sector, bank staff, and where we can provide mutual aid. And then the other focus with that was the well-being and resilience of our staff, which was of paramount importance after our learning from COVID. Next, we focused on communication. How do we communicate with the public? What sources do we use? How do we ensure consistency in our messaging? Ensuring we have a proactive response to misinformation, and how we engage with the wider community. We know that communication in the next round of pandemic is going to be very different following COVID, and it's gearing up as a system to respond to that. And finally, we focused on command and control, what mechanisms we'll use to ensure that we have appropriate command and control of the situation, what our triggers are for setting up strategic and tactical groups, what cell structures we'll need. And all of this was based on our learning from COVID. So we have a lot of that in the bank, so to speak, but what we also focused on was capturing organisational knowledge. People will leave and we will lose some of that knowledge with them. So that was a key focus, that we're capturing everything that we did previously. We also identified risks and challenges. So there were some risks and challenges that we as a system could mitigate, making sure we had our plans up to date. We were supporting our staff, we were continuing training, we were looking at mutual aid, and we were jointly testing and exercising. However, there were areas that we needed to escalate back up to our regional, national teams, as well as the government, and that was with regards to funding, supplies of PPE, medication, food, and most importantly, legislation and powers. So during COVID-19, there were special legislation set up that has obviously passed. If we were ever to go back to a situation with lockdowns, isolation, etc., those would need to come into force very quickly to support our police colleagues, especially in being able to maintain those powers. So that all of that has been fed back through Exercise Pegasus. We are just waiting for that report to come back. Learning from COVID has been incorporated into all our pandemic planning, which has led to greater agility, better protection for our staff, our vulnerable groups, the people we support, our communities. As an LRF and as an LLR system, we have enhanced coordination, we have efficient use of resources. So we moved everything online. MS Teams, before COVID, it was, nobody had heard of it, but that's how we've become more efficient, enables us to be quicker in our response, greater organisational resilience, and our ability to maintain critical services during the disruption. So all organisations during COVID looked at what were their critical services, what do they need to continue delivering, and what can we stop doing to focus on support elsewhere. So I've covered some of those things, but virtual meetings, single points of contacts within organisations. So organisations will have that one mailbox where we know things are going to be read. increased use of technology, virtual wards within health, strengthened business continuity plans with like a mutual aid focus, improved IT infrastructure. So the next steps from this is we're awaiting the final report from Exercise Pegasus, which will come from UKHSA, as well as a national pandemic plan. There hasn't been a national pandemic plan update since 2014. So we are working on our local plans. Whether that aligns with what the government wants is very different. So we have requested that what we need is that overall national plan to make sure we are aligned to their thinking. So in conclusion, LLR partners have robust framework and plans in place for pandemic preparedness. We can't guess what the next pandemic's going to be, when it's going to be. We do know that there will be one, and our plans are able to adapt to whatever comes next. And then we just ask the Health and Wellbeing Board to endorse our efforts so far. Thank you. And any questions?
Thank you very much. Conscious of time, I think we can probably afford one or two questions if anybody has any questions. Rachel, then Mike, please.
Yeah, just an acknowledgement about the amount of work that's actually gone into the exercises that Amita's talked about today, and just a recognition that partners have worked really closely together to get to where we are, but there's been an awful lot of work involved in this, so just thank you.
I was going to say the same thing. Thanks to Amita and thanks to Anuj for the report and the work of everybody. And I suppose a more general thanks, isn't it? Because what can we do? Well, we can get the structures in place, we can get the plans in place. I think there's an assumption sometimes that we're sitting on a kind of massive pile of, stockpile of PPE and a massive pile of emergency food, that we've got staff just hanging around, not doing anything else, waiting to be contact tracers and testers and God knows what else. It's not. We've all got day jobs. I know this is your day job, but you know what I mean? It's just part of a large number of things that we do. So there's stuff we can plan for, but ultimately it comes down to the ability of all of us to drop everything, rise to the occasion and support each other, which we did so well during COVID. And that's the thing that we need to keep going as we go through the current changes. So thank you both.
Yep, so PPE has a sell-by date, it doesn't last indefinitely. So we could say, shall we stockpile, but we don't know when we're going to need it. And we can't because it's a waste of money then.
Thank you very much. I mean, it's we had a very good dry run with COVID, didn't we? But no, it was not that dry. No, practice will say. Right, well, propose that the board notes the current status of pandemic planning across LLR, including governance plans, capabilities and risks, endorses the proposed next steps to strengthen multi-agency coordination and preparedness, supports the continued integration of pandemic planning with broader health protection, local resilience forum and emergency preparedness, resilience and response frameworks. Can I have a second, please? Thank you. All in agreement? Thank you. Okay, agenda item 12 then. Last report is the joint local health and wellbeing strategy, which is on pages 109 to 174. This report will be presented by Joshna Mavji, Assistant Director Public Health, and Abby Vaughan, Health and Wellbeing Board Manager.
Still cool, but I think we are.
Yeah. So thank you, Abby, to all the work you've done on reviewing the strategy. I know it's been a big effort putting it all together, particularly the couple of issues we had. I understand that Joshna is leaving the council, so I'd like to thank her for all the work in Leicestershire, and I'm sure the board will join me in wishing her very well for the future. Over to you, Abby.
Thank you, Chair. I'll keep this short because you have heard lots of presentations regarding the strategy. So we're delighted to finally present the revised and redesigned joint local health and wellbeing strategy for your approval, and it can be viewed in the appendices of this report. So following the board's approval in September to
update the strategy on the recommended changes that were put forward. We undertook the process of updating the document, and the revised strategy is now complete, and we seek approval today and endorsement of the next phase of activity, and they are set out in paragraphs 15 and 16 of the report. So our strategy is firmly rooted in the needs of Leicestershire residents, underpinned by robust evidence and aligned with key local and national priorities. We've ensured strong alignment with the NHS 10-year plan and our neighbourhood work, and incorporated some strategic priorities around both of these. The process has been highly collaborative, involving partners at system, place and neighbourhood levels, ensuring voluntary sector voice as well. Our agile governance has enabled strategic focus and effective decision making throughout. So while the core of our strategy remains unchanged, reflecting the ongoing needs of our Leicestershire residents, several important updates have been made. Outdated information has been removed. New content such as the NHS 10-year plan has been added. Commitments have been streamlined, broader in scope and more flexible to changing needs without requiring frequent refreshes. And the COVID-19 recovery priority has been replaced by a focus on health protection and emergency preparedness. The document is now more user-friendly, we hope, and visually engaging, with each section clearly colour-coded with unique icons. We tested the new format with colleagues not involved in the project, and their positive feedback has confirmed that it's easy to navigate, read and understand. So that's quite positive. Our immediate priority is to develop a delivery plan that will translate the strategy into actions. So we'll make this very much a live document, and we aim to present this plan at the Health and Wellbeing Board meeting in February. So please note that the plan that we intend to present will be organic and regularly updated. It'll be a live document with subgroups reporting the detail as our mental health colleagues reported on some of our current priorities today. Additionally, we'll produce an easy read version of this document to access the accessibility of this document, and a communication and engagement plan is under development with some stakeholder mapping and analysis taking place as we speak. We want to ensure that the strategy is widely promoted, understood and also embedded across all of our partnership organisations. So we're very proud of the collaborative effort behind this strategy and confident it positions ourselves to meet the evolving needs of Leicestershire residents. And we look forward to your feedback and your approval to moving forward with the next phase of delivery.
I'll just add, sorry, to the end of that as well, just to say a huge thank you to everybody that's been involved. Your contributions have been fantastic, and I guess it's just to show what the power of partnerships can achieve. And really just to say, again, and echoing a huge thank you to you, Abby, for the meticulous coordination. I think everybody would agree, and doing a phenomenal job of keeping us in check. So yeah, just well done.
Just say, as I've always said, thank you, because this has been, I know it's not been an easy task, and all the coordination you've done and getting us all together. It looks amazing. It reads well. I love the, like you say, the colour sort of changes between the different sections, but also I love the fact that we're now being very clear to saying to people what would success look like. And I think that was always, to me, the bit that I think we always struggled with when we were looking at some of these groups about, if we're saying that's the commitment, what's going to tell us that maybe we've got there, or we can say actually that looks good. So I think to have that in there as well is great, and also I think it would be really good to see the easy read when it comes out as well, because obviously there's a lot there. To have that sort of easy read as a bridge version would be great as well. But well done, it looks amazing.
More comments. I really value the opportunity to contribute, and I think we're very new on our agenda in championing care experience young people. And then very recently, we agreed as a council that there'd be a protected group and protected characteristic. They're quite often a group, our children leaving care, who face the cliff edge of services. Our services aren't well designed to support their needs and their continuity when they don't have, usually don't have strong parents or support groups to turn to, and yet our services are designed to make things, well, they do make things difficult for them. And they're quite often our young people who face health inequalities across the board. So I really welcome the opportunity to get them firmly on this agenda and in this plan. So thank you very much.
Yeah, thank you. I think what's key, alongside obviously repeating the thanks, is that this is a working document. It isn't shelf fodder. It's something that we will absolutely utilise and work through and report on regularly. And also, I just want to give ICB assurance that we'll be using the Joint and Health and Wellbeing plan as part of our planning strategy as we move forward. And I'm sure that's the same for lots of organisations, but having the refresh done in the way it's done will make our neighbourhood work much easier because we've incorporated so much of that in already, but also our wider ICB planning will link into the revised strategy.
Nice when a plan comes together. Anybody else? No. Okay. Well, thank you very much. I must say, looking at it, I'm very impressed with the design. Very good. So I will propose that the board approves the final version of the Joint Local Health and Wellbeing Strategy 22 to 2032, reviewed and revised 2025. Have a seconder? Yeah. Okay. All in agreement? Excellent. Okay. Thank you very much. Yeah. Yes, yeah, and kept it interesting as well. Well, we've got to actually finish the meeting now, haven't we? Okay, so agenda item 13, urgent items. There are no urgent items. Agenda item 14, date of the next meeting. The next meeting of the board will be on the 26th of February 2026 at 2 p.m. I'll see you there and I'll draw the meeting to a close. Thank you for your attendance.